Hello, everyone. Hello, Dr. Vishali, Malika.
So we are live.
Hi. Oh,
Okay. Good evening, everybody, and a very big namaste to all of you. So, Itis is a series of programs which is being done under the aegis of AIUS with Sun Pharma helping us. So, I'll just introduce one or two slides here. So, so many webinars you see having a, is it audible?
yes, sir.
Okay. So many webinars being held every day. In fact, we were just chatting that all of us are fed up or maybe, aimlessly doing a lot of things. You see, although webinars are increasing and paralleling corona cases, but I don't know how much they are contributing or helping knowledge gain. But earnings are obviously going down because the number of patients coming in each clinics are much, much less. So in fact, webinars, sometimes you get so much fed up that you see another itis, that is webinitis, which keeps hitting you. There are 3 to 5 webinar, 5 to 7 webinar, 11 to 1. And I know Partho is saturated, must be his third webinar today. So in any case, we have to fulfill our, you see, COVID, positive point of COVID is that the education has become slightly simpler. Communication has become easier nationally, internationally both. So I just want to start with a positive note. Zindagi jo hai na, is thodi unusual si ho gayi hai. So I just play just to decrease the stress.
बड़ी अजीब सी है जिंदगी, जो चाहा कभी पाया नहीं, जो पाया कभी सोचा नहीं, जो सोचा कभी मिला नहीं, और जो मिला रास आया नहीं, जो खोया वो याद आता है, और जो पाया संभाला जाता नहीं.
Is it audible?
Yes, sir.
Yes, sir.
Okay.
क्यों अजीब सी पहेली है जिंदगी, इसे कोई सुलझा पाता नहीं. जीवन में कभी समझौता करना पड़े तो कोई बड़ी बात नहीं, क्योंकि चुपता वही है जिसमें जान होती है, अकड़ तो मुर्दे की पहचान होती है. जिंदगी जीने के दो तरीके होते हैं. पहला, जो पसंद है उसे हासिल करना सीख लो, और दूसरा, जो हासिल है उसे पसंद करना सीख लो. जिंदगी जीना आसान नहीं होता, बिना संघर्ष किए कोई महान नहीं होता. जब तक ना पड़े हथौड़े की चोट, पत्थर भी भगवान नहीं होता. जिंदगी बहुत कुछ सिखाती है, कभी हंसती है तो कभी रुलाती है, पर जो हर हाल में खुश रहते हैं, जिंदगी उनके आगे सर झुकाती है. चेहरे की हंसी से हर गम चुराओ, बहुत कुछ बोलो पर कुछ ना छिपाओ, खुद ना रूठो, कभी सबको मनाओ. राज है ये जिंदगी, बस जीते चले जाओ, बस जीते चले जाओ.
This was just to relax. This is what I feel Zindagi is actually. You see, along with the Milmet Sun Pharma company, we are doing this series of Itis webinars. The first one was done last week with Dr. Partho and Dr. AG helping us. And we had very nice panelists with us. But we had 4 main talks, 4 talks each of 15 minutes. And each had discussion also 15 minutes. First was conjunctive, sclera, cara, and uvea, all itis. So we covered entire uveitis. And today, what we plan to cover is 4 more itis elements, which includes uveitis posterior, because there are a lot of misdiagnoses. People do not understand and they mislabel everything is tuberculosis and they start steroids or whatever. So, and then we have another talk, endophthalmitis, which again is not appropriately managed a lot of times. And another, entity which itis was orbital cellulitis. Here again, it's an virtually emergency condition. You see, all these 4 conditions, including optic neuritis, are reasonably emergency conditions. If you miss the bus, believe me, person may lose the vision forever. And we have very eminent panelists with us. All of you know Malika Goyal, Santosh Shunawar, Sumit Monga. And I need not introduce Partho at all because he is world-renowned figure with us, Chairman Scientific Committee of AIUS. After having done wonderful, wonderful work as Chairman ARC, now he's taking care of Scientific Committee. So we'll consider all these 4 topics. My only request to all the speakers will be, please stick to time of 10 to 15 minutes at the upper limit, and let's have some question answers and discussions. So 4 talks and 4 speakers, 4 very important topics, and very nice panel which we have. I'll not come in between the Itis part now and all the speakers. And let's begin the session with Dr. Vishali Gupta, and whom you all know is doing wonderful work in the field of vitreoretinology, and she is a professor at PGI and is known for her work all across the world. So may I request Vishali to start sharing her presentation. She will tell us about posterior uveitis. You see, thrust of all these talks in Itis are what everyone should know and should not miss in his practice. The aim is not to enlighten you for all the aspects. Aim is that we should know this much minimum. Everybody should know this much minimum and should not miss once a patient comes. So over to you, Vishali. I'll stop sharing my screen.
Thank you, sir. It's a pleasure for me to be participating. Dr. Lalit Verma always comes up with very, very interesting ideas, and I love this Itis part of the whole thing. And wonderful to have panelists and see friends. Hope I'm able to do justice to the topic. So what are the itis in posterior uveitis? We have retinitis. We have retinochoroiditis, which means that whenever retina is inflamed, the part of choroid would get involved, but the primary disease is retinitis. Then we similarly go on to choroiditis, where choroid is primarily involved. And then whenever choroid is involved, the overlying retina will be inflamed. So it becomes chorioretinitis, and finally vasculitis. So a beautiful question put by Dr. Verma was, what should not be missed? And I'm not talking here to the uveitis expert, I'm talking to all of us who happen to bump into these patients. There are 6 points. One is one should not be confusing between retinitis and choroiditis, and that is the crux of the whole thing. Do not confuse between non-itis and itis. Do not confuse between infective and non-infective itis. Do not miss masquerades by just labeling them as choroiditis, because that's a very convenient thing to do. And not to confuse between the complications of itis and the recurrence of the inflammation. And finally, if I have some time, I may talk briefly about pattern recognition in vasculitis. Now let's see the case examples. The first thing which I said was not to confuse between retinitis and choroiditis. Why? Because the moment you see retinitis, the chances of it being infective are quite high. How does retinitis present? It can be either focal or diffuse, and I'm going to show you examples of each. If it is focal, there are 2 main etiologies. I'm not talking of the rare things here. It can either be Toxo or it can be Behçet's. If it is diffuse, for all likelihood it is viral and very rarely Toxo. So let's see this patient who comes to you. Now this is retinitis, and for the youngsters who are with us, you see it is fluffy white. You don't see blood vessels which are crossing it very clearly because it's a part of the retina which is inflamed. So when you look at this patch of retinitis, you may see overlying vitritis, and it may appear sometimes headlight in fog. The moment you see it, it is Toxo. Many of you might have read in the book that Toxo comes next to the congenital scar and there is a satellite lesion and there is all that stuff. But believe me, those are not common. Most of the time, Toxo is acquired. So if you are seeing retinitis like this, which are the features that I have already mentioned, you may have fluid which is surrounding this lesion, but it is going to be creamy white and the edges are not so well defined. You may do fluorescein just for the heck of it these days, I say. But what you see, if it is an active disease, you will have early hypo becoming gradually hyper and you have a pocket of fluid. But to me, it's more important on OCT. As you can see, it's the retina which is involved and you can see the choroid is not involved. What you are seeing is you are not seeing underlying choroid because the retina is inflamed. And of course, there are cells in the vitreous. And these days, vitreous cells are actually better seen on OCT than, clinically. So retinitis, I just mentioned. When I see retinitis, to me, it's either Toxo or Behçet's. But this one is so classically Toxo and there is no vasculitis. So what do I do? Honestly, you can get IgG and M if you want, but it really doesn't alter the management. So if your clinical acumen is good, go ahead with the treatment and this is what you end up with. We will not go into the details of the treatment, but you see the lesion responding very well to antitoxo therapy. This is, on the other hand, is another case, which again, if I show you, it's bilateral. You have these small patches of retinitis. They do not look like Toxo because you don't have that headlight and fog. And there is something happening to the vessels in the periphery, to a fluorescein. A fluorescein here shows the leakage from the capillary. And please always keep this picture in mind. If you see, this is called Fern tree pattern. So if you see these branches like the fern tree, this is always more than 95% chances of this being Behçet's. Though very rarely the other diseases like TB and all might show, but if this is in context to retinitis, it's invariably Behçet's. Ask the history of oral genital ulcers and other things to rule out Behçet's disease. So this was my point number one, that you got to differentiate retinitis from choroiditis. So many of you would come up with a very simple question, why the hell, why I need to know it is retinitis? And I will show you a case example. Now this is the patient. The first picture, what you are seeing is seen elsewhere, a big center, and it's labeled as choroiditis. But if you see it very clearly, this is very typical picture of toxoplasmosis. It is retinitis. It is retinitis. So if it is retinitis, it is retinitis. It got to be infective. You got to rule out toxo, but that was not done. Instead, intravitreal steroids was injected with the diagnosis of choroiditis. And see what happens. The middle picture is the one when we saw him. It's a diffuse disease which has progressed because somebody failed to just recognize the phenotype. You don't need complex investigation. You just need to look at the patient. And the last picture is after antitoxo treatment. Though we could heal the lesion, but there is no fun because we lost the fovea and the guy lost his central vision. After the retinitis, we come to the choroid, and when it is choroiditis, you can see it is deep, it is dull yellow, and you can see the overlying vessels very, very clearly. Now, choroid has a very, very specific way of showing the insult. It can either be focal, which can be unifocal or multifocal, or it can be diffuse. Now, suppose this patient comes to you and the picture on the left, you see it's deep-seated, it is unifocal, it is large, and you also see these small hemorrhages on top of it. if you see a granuloma like this is very classically of TB. Because when you see a granuloma in the choroid, there are two differentials, TB versus sarcoid. TB granulomas tend to be single, they tend to be more oval, and they tend to have these hemorrhages and CNVMs on top of them because TB is VEGF-driven disease. So you treat it and you will end up with a result like this. Another form of choroiditis, which in this country is everywhere, is Serpiginus-like choroiditis, which is associated with TB. Now, this Serpiginus-like choroiditis, you can identify because of its multifocality. You may have cells in the vitreous associated with it, and you may have some little bit of vasculitis. And this is the point I would like to show. The patches of choroiditis coming along the blood vessels, which is called perivascular chorioretinal patches. These are very highly typical sign that you may have an underlying TB. So please don't be, you have to give steroids, but test for TB, and those tests, if come positive, you will have to add anti-TB drugs to prevent multiple recurrences. And the picture on the left is another patient which shows a diffuse variety of choroiditis, again due to tuberculosis. As I mentioned, that choroid has a very typical, because of its anatomy, which is the lobules. It will present either as focal or as diffuse variety, because focal is each lobule involved, and when they become coalescent, they will form a diffuse like this. Choroiditis will not produce as a linear lesion because that's against the anatomy of the choroid. So we come to the second point, how not to confuse non-itis with itis. Now see the example of this patient. This patient has been diagnosed as TB choroiditis, received steroids, received ATT, has been deteriorating. But if you look at it, fair enough, this is not retinitis. But if you look at the morphology, this is not choroiditis as well. So what is it? This is something happening in the subretinal space, and this is fibrin. Before we go into this, I would just point out that if you see this dark spot in the center of the yellow lesion, think this is more of a fibrinous CSC and not choroiditis. So what do? We do the fluorescein, and what you see, the dots which are expanding. If it is choroiditis, it will be hypo in the early phase, becoming hyper in the late phase. If it is CSR, it is hyper in the late phase and becomes expansile and more expanding in the later phase. Only thing we have done is just to stop steroids, and you can see that after stopping steroids, the patient has responded very well to therapy. The question was, and many of you must be wondering, was it TB choroiditis to begin with, and after treating it became? So we asked the patient to get the angiogram, which she was seen for the first time, and you can see that the first time she ever presented to the ophthalmologist, it was actually CSR, which was mistaken as choroiditis. But if you pay attention, this linear thing here and these dark spots, it cannot be choroiditis. So this is just another example of this patient has actually received IV methylpred, being diagnosed as VKH, but this is not VKH because this is not the fluorescein. And again, you see the fibrin deposits and you see this dark spot. The dark spot is because the fluid is leaking in CSR and it is displacing the fibrin. So these are some of the classical examples of non-itis being mistaken as itis. So if you're not sure, please do not be in a hurry to push in IV steroids and all, because you can do more harm than good. The third point is not to confuse between infective and non-infective itis. And this is just an example of diffuse retinitis. As I said, retinitis by and large are infective, So if you are seeing this diffuse variety of retinitis here in the periphery, and you start patient on steroids without thinking of viral as a possibility, you are going to create havoc, and actually havoc in both the eyes. So this is just what happens. The disease just progresses very quickly. Another example, how important it is not to mistake the two. Now, this is a one-eyed patient. Let's start from the top. This patient was seen and was diagnosed as sympathetic ophthalmia because something is happening just close to the disc. Fair enough. Patient was not responding to very well to steroid. And look at the pattern. This is peripapillary choroiditis. This is not how sympathetic ophthalmia would present. So patient receives immunosuppression because not responding. Patient is progressing. If we go to the third picture, there is some occlusion and few cotton wool spots which are mistaken as toxo, and she receives anti-toxo. And this bottom is where we saw her for the first time. She's actually positive for TB, and the final picture is response to anti-TB and anti-VEGF, which we sometimes combine for the underlying new vessels. That's not the point. The point is, when you see here, it talks like a duck, walks like a duck, got to be duck. You know, it's a choroiditis. It's a diffuse choroiditis, which has an edge. So even if it is one-eyed patient, even if you have trauma in the other eye, you got to rule out the common thing, which is tuberculosis, or maybe syphilis or something else. But you do not keep on pushing IV methylprednisolone because that poor lady had trauma to the opposite eye 20 years ago. So this is what I'm emphasizing on, is to recognize the pattern. Again, an example. Now, I have already shown you choroiditis, and just I'm going passing with sometimes, I'm not going to talk about metastasis here, but some of these leukemias, lymphomas are very classically subretinal. Now, this child, he might be having fever, he might be having cough, he may be having lethargy, but this does not look like TB choroiditis for the simple reason it's not yellow. For the simple reason you can see these blood vessels running over this, they are dilated, and you can see that there is something which is happening very close to the retina. And this child actually was diagnosed as ALL, and this is how following the treatment for ALL. Always remember that whenever we see a posterior uveitis patient who's either too young or too old, the autoimmunity by and large gets tired when you are above 50. So always, always try to rule out masquerades and malignancies. This is another such example. You look at the pattern. This is not truly retinitis. Neither is it choroiditis, because as I explained you, it doesn't fit in either. So what is it? Get a OCT done through the lesion, and OCT shows you beautiful elevation of the lumpy, bumpy, and subretinal deposits. So these subretinal deposits are very typically deposits of lymphoma. Don't miss. Get an autofluorescence done. You will see that leopard skin appearance. And you know, these are the kind of the patients you probably would need to recognize and refer, because if you push in steroids, they will respond. Lymphomas respond. So you are not only delaying the onset of diagnosis in the eye, but you are actually delaying the onset of CNS lymphoma and even the life expectancy of the patient, I must say. My fifth point, do not please confuse between the complications of inflammation and the recurrence of inflammation. And this is what we are seeing now very commonly. This is a young girl who actually comes from Calcutta, and she is already on immunosuppression, received ATT, she's scarred, she's a smart girl. She says, I have metamorphopsia, and I have been told to add another immunosuppressive drug. Okay, so I did not see any to be very honest, any activity of the choroiditis got the fluorescein. And if you look at the arrowhead, there was something happening. But believe me, this arrowhead I have put in retrospect. When I saw this fluorescein on Optos, I said, oh, there's nothing much happening. It all looks healed to me. So we do OCT angio and we see this network of new vessels here. So they were there, and many of you will say, oh, they're just mature network, because all our understanding of new vessels come from AMD. But listen to the patient. So we did inject her, you can see on the top, and then you can see here is after 7 weeks, the new vessels did regress. And then we thought probably we do not know, let's wait. And 14 weeks later, you can see this increasing again, vision going down again. So I'm not saying that you monitor every patient, but what I'm saying is if you see at this stage and you're not able to figure out what is going on, just do not push in another immunosuppression because you think it is activation of the lesion. It may not be activation. Another example, this is Cmv Retinitis. We started him on treatment. He was responding, comes with decreased vision. And this time there is a small little hemorrhage. So please examine the patient very carefully, because many a times these patients may be having something else which needs your attention other than simply the infection that you are seeing or the healed infection that you might have seen. My last 3 slides, if the time permits, I would talk about vasculitis. So what is vasculitis? Characterize, like you characterize retinitis, choroiditis, characterize vasculitis. Is it phlebitis? Is it arthritis? Or is it capillaritis? I have already shown you the example of capillaritis is Behçet's, phlebitis is mostly TB, sarcoid, arthritis is Irvan and Takayasu's, and we will not go into that detail. Again, try to recognize, is it focal, diffuse, and very importantly, does it have associated lesions like choroiditis, retinitis, because that will make a very important clue towards possible etiology. 2 of fluorescein, because you can see the condition like Behçet's, just based on the fluorescein you can diagnose. See any systemic association, shortlist your differential, targeted labs. I will not go into fluid analysis. Now, this is just an example of Behçet's again. So you see there is vasculitis. This is again, the capillaries are leaking down here in the bottom slide. Ask patient to open mouth, oral ulcers, nothing else is required. Don't go in for extensive workup, just spend time on the character of the lesions and time on the patient. 2 clues for TB vasculitis. They tend to be occlusive in nature. So you will find the areas of capillary non-perfusion in the periphery. You may have associated neuroretinitis and choroiditis. If you're seeing these patches of choroiditis along with vasculitis and neuroretinitis, always examine the opposite eye, which may show you very characteristic healed perivascular lesions. So these are the signs which are very, very diagnostic for possible TB etiology. So I'm not going very extensively. I'm coming back to my original slide and I'll be happy to answer any questions. So what you should know. First, you should know what you are dealing with. Is it retinitis or is it choroiditis? Second, you should know if it's not choroiditis and it is not retinitis, is it really an itis or is it some funny variety of non-itis like CSR, fibrin, or something else which you are confusing with itis? And why is it important to know? It is important to know because the moment you diagnose CSR as TB or as VKH, you give steroids. So you cause the worsening of the primary disease a lot. So it's very important that if something is not fitting the bill, spend some time on the patient rather than just be in a hurry to inject. The third thing is not to confuse between infective and non-infective. That I showed you example of peripheral retinitis. If you think it could be even an iota of chance, it could be viral, don't ever think it would be non-infective. The fourth is if there is something happening in the subretinal space, and that too either in the children or in the adults or even in the youngsters, the subretinal space is not a place for usual uveitis. Rule out masquerades. Fifth is do not confuse with complications of itis, because CNVMs are very extremely common simply because your patient is having a deterioration of vision and metamorphopsia does not mean you need to add another drug to it because you think it is activation of uveitis. And believe me, I don't know about you, but I still find it very difficult to interpret my fluorescein angiography in the hula bula of all those scars and all. So one can easily miss CNVMs. You got to look out for them. So if the uveitis seems healed to you, just do not add another immunosuppression. Look back, think what it could be. And for vasculitis, just a pattern recognition would be good. Don't order everything from, everybody. Thank you very much. And thank you once again for giving me an opportunity to be on this platform.
Truly wonderful, Vishali. The way you built up the entire story, believe me, it was very, very nice. See,
Thank you, sir.
We keep hearing a lot of talks on uveitis, but the way I think you built up those 6 points, I really like that. Let me open it to the panel in case they want to clarify or maybe, put it in some other way for the benefit of. Yeah, Malika.
Vishali, I think that was that was a great lecture, and I think you put it simply.
Coming from you,
बच्चों का खेल है.
No. Coming from Dr. Talwar.
The one point which I wanted to, after hearing you, the one nichod which I got, which we are old timers, me and Lalit, and I think he will agree with me. The one thing that actually you have stressed without actually putting it in the end was fluorescein angiography does 90% of your job for you. It will differentiate choroiditis from neovascularization. It will differentiate acute choroiditis, active choroiditis from healed choroiditis. It will also differentiate a choroiditis from a neovascular, from a tumor. So actually, the problem what has happened is people have lost the art of doing a fluorescein angiography, which probably would give you so much information when you combine it with the information you get from the other things now.
So also OCT through the pathology. Most of the times it's through the fovea it doesn't give. So through the pathology itself gives.
Like you saw the burning, you saw.
Fluorescein has taken a back seat. But if you have all the frames from beginning till the end, like the patient you showed in CSR wala, you see, if fluorescein was not there, you see people, sometimes will misdiagnose as CSR has been repeatedly misdiagnosed as tuberculosis, and patient condemned actually to ATT for 9 months, which is not required. Most of the CSR, in fact, I don't think that CSR is a TB at all. In fact, if you see our old-timer teachers also, they should say multifocal CSR, TB, ATT trial. All this is bug now. I don't think so. This is relevant. And what I wanted, you see, if you did not have all this multimodal imaging, like you have access to ICG, FA, OCT, Octa. So and what the bare minimum what Dinesh was hinting was at least history taking, good examination and angiography. This will, differentiate between a lot of these entities, and a good clinical acumen, obviously, because what the mind does not know, eyes don't see also. So a good clinical and this play a very important role. You see, anybody who has listened to your talk today, believe me, he will be very much scared to misdiagnose retinitis as, and he will He will never start steroids. You see, basic aim of your talk was, in a retinitis, do not jump to steroids. Like that one-eyed lady you showed, right eye, and he ultimately was victim of an iatrogenic kind of blindness, unnecessarily. Let me put it very blunt, actually. You see, if suppose it was diagnosed properly at Vaishali's hospital or whatever, so this would not have resulted in, although the lesion got healed, but ultimately patient lost the vision. Yes,
Sir,
Malika,
I think clinical is very important. We don't have that patience. We straight away send patient for imaging, like our younger lot. I mean, they think if OCT are these fancy things are not working, probably they won't. So I think clinical is still the most important to me.
Let me take 1 or 2 points from Malika as well as
sure.
other panelists. Then we move on to the next.
Wonderful lecture. I need not even say that. One important point you made was if the lesions are along the lobes versus linear, it's not choroiditis. See, the first case where you showed a creamy white lesion, it could also be candida, an endogenous lesion. Only thing is, possibly that would have less vitreous inflammation than toxo. So if it is not responding to anti-toxo, consider investigating for fungal endophthalmitis. The only areas where retinitis could benefit from steroids could be a post-dengue, post-chikungunya, or SLE retinitis. So these are the only situations which can be non-infective, but otherwise large, or Behçet's also. So these are the 4 conditions where you could have a non-infective kind of retinitis. There was a patient where you showed with sympathetic ophthalmia and they had started treatment for, it was a TB choroiditis and started for sympathetic ophthalmia. One good way where when in doubt is before starting treatment for sympathetic, they could have done a B scan and that would immediately pick up if it is a sympathetic ophthalmia, there would be significant choroidal thickening, which you may not see in a localized TB choroiditis. Also, when there is a doubt about diagnosis, avoid intravitreal steroid. You can give oral because of the CSR complication, which can be disastrous if it is CSR, if you give steroid. And also, if you give steroid in an immunocompromised patient, they may not reveal their history of HIV, and you may think there is choroiditis and give intravitreal, or even for CME post-operative, they develop Cmv retinitis. Even if they are diabetics sometimes, not even HIV positive. So we have to be very, very careful of giving intravitreal steroid in a patient, any patient. We have to rule out a lot of things, CSR, immunosuppression. Neuroretinitis, sometimes it looks like neuroretinitis, but it could actually be posterior scleritis. So a B scan, especially if there is pain, severe pain. So a B scan would make the diagnosis because then the etiology is quite different. Neuroretinitis, you start looking for infections. Scleritis, you generally treat with steroids. If it is bilateral neuroretinitis, you should think of high blood pressure as a possibility.
High blood pressure,
or raised ICT, raised intracranial tension causing chronic papilledema and macular star. So these are, which would be very easy to know if you have it in the mind. And if you have CNVM in a patient with choroiditis and there is some activity, then just anti-VEGF may not do. You might have to add steroids as well. And now if this choroiditis is tubercular, then you also have to add anti-TB. So, so when you see a CNVM with choroiditis, you do the investigations. If strong Mantooks, the morphology is very much suggestive of tubercular choroiditis, then I think it needs a triple therapy. It needs ATT, it needs steroids, and it needs anti-VEGF. I may be wrong.
No, only thing is TB choroiditis by and large present after healing. The membranes are lurking underneath. So they might have already received all the treatment, but then the patient complains of some metamorphopsia, and when the treating physician sees, they think there is recurrence of the inflammation and they tend to go in that direction. So, but it may be just the healed disease, not the recurrence, but CNVM in the healed scars. So that's what I was trying to show.
If it's treatment naive, you would probably...
treatment naive, you would probably combine both the treatment. Yes, absolutely.
Shali, once you said that, you see, TB is a VEGF-related disease, I wanted to have some...
So that is a beautiful experiment done on the zebrafish, which is a transparent model. They created TB granulomas and then cut off the VEGF supply, and the granulomas subsided on their own. So we have started actually treating TB granulomas with anti-VEGF. And we have even reported only monotherapy with anti-VEGF without adding ATT, but unfortunately, the disease comes back. So I will not go overboard and say that if you see TB granulomas, you treat with anti-VEGF. Yes, you add anti-VEGF as an adjunct because many of them would either have a RAP lesion or small hemorrhages on top of them. But you also give the standard of the care, which is anti-TB therapy and steroids if required.
But Vaishali, it could be just that the anti-inflammatory effect of anti-VEGF agents is what works. It may not be an anti-VEGF effect per se.
Sir, what Dr. Rao has done experimental model mein where they created the intraocular TB, they found very high levels of VEGF in the vitreous compared to the non-TB model. So they are
other retinitis.
Has
anybody looked for those in other retinitis and other choroiditis?
This is the experimental model of TB.
If you find the same in other patients with choroiditis, then it's not related to tuberculosis. It's related to choroiditis per se.
Yeah.
And the anti-VEGF may work because it has anti-inflammatory properties.
Properties as well.
Anti-VEGF properties.
But it works.
Yeah, I know. But
it works.
The good thing is it works.
AG, yes, AG. Yeah, AG.
Sir, I have two questions. At the moment, pyrazinamide is not available in the market. So what is the first line of treatment you give for Toxo retinitis at the moment?
We are giving local treatment. We are giving local.
Clindamycin.
Local means intravitreal clindamycin.
Intravitreal clindamycin.
Okay. So how many injections do you feel the patient...
Nobody knows, but by and large, these are twice a week injections, and generally by 3-4 injections, patients do fine. Sometimes to give us consolation, we do add Septron along with it, but that's more of a, I mean, there are multiple studies, but nobody has actually shown that Septron adds, but you feel better that patient is also taking.
You combine systemic clindamycin along with intravitreal clindamycin?
No.
Second thing,
we just give intravitreal.
Second thing
but now that we are getting smarter, we give only intravitreal. We sometimes do not give any systemic at all.
Expensive therapy.
Second thing about the case, what you showed about CSR case. I also had 2 or 3 cases, and those cases after 2 to 3 years of resolution, they came out with CNVM. And at that stage, I realized that these are pachychoroid disease, and that is the presentation. These are pachychoroid spectrum of the disease, and these patients are requiring anti-VEGF at the moment for CNVM.
But incidentally, this kind of fibrin responds to anti-VEGF agents.
It does, but many times it rips also. If there is too much of fibrin and it stents and you inject, it has a tendency to cause RP rip. So we have 2 or 3 patients where, so it's better to stop steroids, let it regress, and like a brother is.
Steroids, but what I mean is that as a management, you can also add anti-VEGF agents, and the fibrin does respond to the anti-VEGF agents.
So sometimes the RP rips if it's too tense, so one has to be very careful.
As a management, what would work is laser for the leaks, which you're already seeing, or photodynamic therapy, which I have done with excellent result.
Yeah.
So with due regards to all the discussion, I would not like this message to go about anti-VEGF. I would say ATT plus
ATT, standard of care.
Anti-VEGF, please don't, if Vaishali utters this word, anti-VEGF should not become the question which I have.
They are not.
Should not. Even though there is a lot of evidence what Vaishali was saying, and they cut off the VEGF. But let this, not go into the public that this treatment for TB is anti-VEGF. Otherwise, you are having injections. So ATT and steroids form the backbone of treatment. And intravitreal clindamycin, at least I have given in more than 19-20 patients now. Only intravitreal clindamycin I give once in a week for 3 injections, and patient recovers fantastically. I sometimes add oral steroids. I do not give intravitreal, but I give oral steroids. Yes, AG. Last comment.
Sir, last question. There was an choroidal granuloma which you diagnosed as tuberculosis. Why? How do you differentiate with this granuloma with scleritis?
We always get the ultrasound done for the T sign and the corroborative test for TB. Like I'll show you, I mean, I did not have very interesting. There is this patient, a young girl, 4 years, she started with typical Serpiginus, now a huge choroidal granuloma. Nothing has worked. And she had parotid. I got her PET scan. FNAC from parotid shows she has some Watkins tumor with tuberculosis, and it's known to have. So, you know, tuberculosis anywhere in the body, if we are able to pick it up on imaging with Monteus and quantiferon, though quantiferon government of India says has been banned, but that is for pulmonary TB. Here we are looking for any evidence. So if that is the case, then we treat it as tuberculosis. So scleritis, we look for the T signs and get sometimes pain. Pain is another differentiating feature.
Many times the physician says ki, I don't find any signs of tuberculosis. Now you decide whether you want to start ATT or not. So
I will not start. I will not start if I do not have. And now we have the consensus on this, which is collaborative ocular TB study consensus. So the experts have said that if you have the clinical phenotype like tuberculoma, which is very much suggestive of TB, even one of the sign, either Monteus or quantiferon, or just the radiology is positive, you can initiate ATT. But if all three are negative, then we are not on any ground to start ATT. So many a times you may have to do PCR or find something, but not presumptive now.
anytime you have instructed your physician with your clinical acumen that you should start on anti-tubercular, or it's the physician who starts the anti-tubercular and you follow?
Generally, we start and we follow, but we have physicians who see them once. And if the LFT goes abnormal, then I ask them to look at it, but not as a routine. They do not see every patient.
AG, a lot of times I have started personally without asking clinicians.
I start it all the time. Because they waste time.
Clinical picture and either Montu or quantiferon is huge. So I take a picture of that hand also. And you see, between quantiferon and Montu, I think both quantiferon is not better than Montu in any case.
No, not at all.
So ATT is started by the physician or an ophthalmologist? That's a question.
I started. I mean, we all started, but then we get the LFT and everything in place. Yeah.
So physician monitoring
regime, I would not start myself. I would rather ask the physician to start the 4-drug regime.
But
because, you know, we used to start the 2-drug regime of INH with rifampicin once upon a time.
No, आजकल नहीं करते 2-drug.
Yes, but we don't do that. Now we don't give that regime, and the 4-drug regime, I would like the physician to be involved actually.
No,
I think you would be involved.
But there's no harm if you are pretty sure of the diagnosis. You can ask the patient to consult a physician and monitoring by physician, but there's no harm in starting by ophthalmologist at all.
But Dr. Dinesh, you have to tell the physician that this has to be started.
Yeah, so
if you send it to them, 90% of the time they say there is no active disease, so we are not starting. So they have to be with you, but they should not be decision makers.
I think we will move on. We will have one comment by Dr. Partho Biswas because he is a convert from posterior to anterior. He will have a wealth of information on this.
So thank you very much, Dr. Vishali. As usual, a fantastic talk.
Thank you.
So much of information. One thing from the comprehensive ophthalmologist point of view, which I would like to suggest, is all posterior uveitis have some reflection in the anterior chamber as well at times. So at times we have missed a few cells here and there. When we see that there is a posterior uveitis, if we go back to the slit lamp again, then there is a little bit of cells here and there, maybe KPs which have been missed. So a good anterior segment examination is very important. And as you very rightly said,
Partho, you are muted again.
All these posterior uveitis, especially sarcoidosis, Behçet's, and VKH, all are associated with the systemic features as well. So to corroborate a diagnosis and to clinch it, the systemic features also need to be assessed before putting forth the diagnosis. For tuberculosis, of course, at our center, little conservative. We always rely on the physician to start the regime, take his opinion, and then start off a regime for tuberculosis.
I think in uveitis, it's very important not to overcommit to the patient in the beginning. Never tell the patient कि आप ठीक हो जाओगे, So they have to be taken along in their management so that they understand what they are going through. So they get disappointed because sometimes their hopes are very high, and we start on a lot of medications, and then they say, then they go to second and third, and that's how their downfall starts. Yeah,
absolutely. And especially if the fovea is not involved and the course of disease involves the fovea despite the treatment, then they feel that it is the treatment which has disturbed them.
Yeah.
So I think with this we'll move on. Vishali, there are 38
Thank
people.
You, sir.
38 people who have congratulated you on your talk.
Thank you, sir.
And
thank you.
There are some people who want you to give algorithm of posterior uveitis.
I will be very happy to do another webinar for this.
Only uveitis webinar.
And last is that one lady wants to know, Dr. Priyanka, can we give spiramycin for Toxo?
Yeah, pregnancy we do give sometimes, but after the local therapy we do not need to give because it's not as effective. At least for me, it did not work too well. So even if it's a pregnant woman with Toxo, we just give intravitreal rather than spiramycin.
Okay, I think we'll move on. Rashmin, already there are 8 questions which have already come from various people for neuritis. We'll ask later on. With this, I think we'll move on to the next very, very important talk that will be done by Dr. Dinesh, which is on basically Itis, which is the most emergency kind of situation, and that is endophthalmitis. No ophthalmologist, in this era should miss endophthalmitis and should not or give intravitreal, because that is one thing which should be known to all the ophthalmologists, because one simple injection can, cure this patient. Or maybe if does not respond, refer to Dinesh for treatment. Yes, Dinesh.
Okay, so thank you, Lalit. I think it was a great idea to have these itis. And so when you have itis and then you have endophthalmitis, so endo is inner, ophthal is the eye, obviously, so the inner part of the eye, and itis is the inflammation. So inflammation of the inner coats or layers of the eye. And the causes could be exogenous, that means the entry is from outside, or it could be endogenous, also called metastatic at times. The entry is from the bloodstream. So the exogenous, the most important is postoperative, which is a dreaded complication for us of cataract surgery especially, and now of intravitreal injections. And then you can have bleb-related endophthalmitis and post-traumatic endophthalmitis, which often is worse because it has the added worse prognosis of the penetrating injury and with more aggressive organisms. So, and the inoculation occurs directly into the vitreous cavity. Now, though the incidence of postoperative endophthalmitis is low, one case is enough to destroy your peace of mind for a long, long time. And the series can maybe even drive you mad. We must understand that postoperative endophthalmitis occurs in 2 major settings. The first one is acute, within 6 weeks of your surgical intraocular intervention, which is usually cataract surgery. And the varying of the presentation is based on the virulence of the organism and the organismal load. It's usually bacterial, but it could be fungal also in our setting. The other one is chronic, which is usually 6 to 12 weeks after surgical intervention and sometimes even later. Now, when you have a patient, when do you suspect endophthalmitis? So once you've done a surgery, first day, can you suspect? Yes. If you have a patient complaining of pain, that is on the first postoperative day a very important symptom. In the subsequent postoperative period, if the patient who was initially improving now says, I've suddenly had a decrease in vision or an increase in pain, these are very important symptoms suggestive of endophthalmitis and should never be ignored. even though 25% of patients with endophthalmitis may not actually have pain. As far as signs are concerned, whether it's the first day or the subsequent postoperative days, the the ocular reaction which the surgeon is used to seeing in his own cases is his gold standard. So you should be familiar with your reaction on the slit lamp on the various days after the surgery. That means how your patients progress in the course of their postoperative period. That is your gold standard. If you have more reaction than that, then you suspect endophthalmitis. If it is not more reaction than that, then you can rest easy. The other important thing is a decrease in glow on a distant direct ophthalmoscopy. This is very sensitive, but remember there can be other causes, so this has a low specificity. And finally, you have exudates in the vitreous cavity. If you see them, this has a very high specificity for endophthalmitis. So if you have a patient with hypopion, and the patient has vitreous exudation on indirect, the diagnosis is confirmed in any of these settings which we discussed before. Does ultrasound make a diagnosis? No. Ultrasound does not help to make your diagnosis, because in fact the vitreous echoes will not occur in the early stage. So when the endophthalmitis actually starts, you may have an echoic vitreous, but you may be seeing some vitreous echoes, exudates if you did a indirect ophthalmoscopy. So ultrasound is not used for making a diagnosis, but it helps us in doing surgical decision making. Now, what if there is no hypopion? If there is no hypopion, you dilate the pupils, look for vitreous exudates, and if they are present, your diagnosis is confirmed. If the vitreous exudates are absent, with the reaction being there in the AC, think in terms of a sterile inflammation or a very, very early endophthalmitis. But if the pupil does not dilate, now what do? You do a slit lamp examination. If there is a very severe reaction and your vision has dropped significantly, say less than 618, it may be worth giving an intravitreal antibiotic. If it's better than 618, you could give cycloplegics and antibiotics and steroids and look for the reaction, see whether the patient responds. Now, this kind of picture with a hypopion is more likely to be infection. This kind of picture, where it's mainly corneal edema, you see a lot of stripe, is more likely to be a TAS, a toxic anterior segment syndrome. Now, how would you differentiate this? See, remember, when you have toxic means in relation to something which caused a toxicity, which will occur during the surgery. So that will occur in the early phase after the post-op, in the post-op period. Infection may occur in the early phase or may occur later. But the important thing is that pain is not a usual component. Lid swelling and chemosis are not a usual component of TAS. Furthermore, if you see the edema is central, peripheral edema is not there. If you see fundus glow is there but mild, but no exudates in the vitreous, then you can think in terms of a TAS. Remember one thing, when you have a doubt, err on the side of infection. So when in doubt, it is endophthalmitis, not that it may be a toxic reaction. And how do you manage your patients? The same as we used to do for many, many years now. Intravitreal antibiotics are the mainstay. Vancomycin plus ceftazidime is the usual treatment, and adjunctive treatment with topical steroids, antibiotics, cycloplegics, and you can add systemic antibiotics. And later on, once the patient starts responding, you can add systemic steroids. But if you get infection within the first 48 hours, say around 36 hours, 40 hours, these patients have got a very severe reaction. Here, I would substitute ceftazidime for amikacin, because I find that is more effective in more severe infections, and the possibility of a gram-negative infection goes up. With ceftazidime, there are more chances that you may get a resistance. But if it is a very fulminant infection, first day you open the bandage and there's an infection, think in terms of much more stronger antibiotics like intravitreal meropenem or tazobactam piperacillin as your preferred choice for this. The adjunctive treatment remains the same. Technique is now standard supratemporal quadrant, 3.5 millimeters from the limbus. Use 30 gauge needles, separate tuberculin syringes, and sequential injections. You can do it under topical or retrobulbar or peribulbar anesthesia, but check the wound prior to injection. If the wound is looking not too good, you may need to put a suture, otherwise it may just pop up. So this is the important thing. Now, once you've given the intravitreal injection, you see how the patient is behaving. If the patient is improving, as you see this patient, the next day you see the hypopyon is less, you start seeing the media, the fundus is seen, hypopyon going down, and it clears up. Nothing more to be done. On the other hand, you have a patient like this, not worsening, but not becoming better. So inadequate improvement. Now you think in this case, it is not responding, it's already day 3, go ahead and do a vitrectomy. And this patient started responding after the vitrectomy. You see, why is this important? Now this patient looks well, oh, day 1 post-op. Now that itself should be ringing some bells. First day post-op means very severe end-off. But the patient got only an intravitreal antibiotic. Told to come after a day, came on day 3 and finished. The story is almost ended. So if you see endophthalmitis on day 1, it is very severe, needs very intensive follow-up, and needs surgery at the first sign of deterioration after an intravitreal if you don't have facilities for a vitrectomy. Otherwise, maybe better to just go and do a vitrectomy. It's important to be aggressive because in this case, both the organism and the inflammatory response will harm the eye. You must refer this patient to a specialist who can aggressively handle this disease. It's absolutely unacceptable to say, I injected an antibiotic and I've told him now you can go and show somebody else. There is no role of multiple intravitreal antibiotic injections except in some very unusual situations. And so refer after the intravitreal antibiotic is the best policy. The best way is give the intravitreal and also tune the patient in that you need to go and show the so-and-so as a vitreoretinal surgeon. Phone up the vitreoretinal surgeon, I will be sending this patient to you tomorrow. So that there is no delay, the vitreoretinal surgeon is ready to take up the case the moment it comes to it. Now this is one of those situations where very hazy, you may be forced to do a vitrectomy. A core vitrectomy, which we normally do a vitrectomy up to equator, is very gratifying in more than 80% of cases. IOL can usually be retained. And remember, an intravitreal antibiotic followed by a vitrectomy within 24 to 48 hours is usually as effective as an immediate vitrectomy even in PL positive eyes. We've done a study on this and found this. Chronic endophthalmitis, on the other hand, poses a problem. The onset is usually more than 6 weeks after the surgical intervention. Sometimes there's a diagnostic dilemma, can be difficult to diagnose, and requires a long-term follow-up because recurrences can occur. The usual causes are P. acne and fungal. These are the more common things. But also keep in mind, if the patient's coming, say, 3 months later, you may think this is chronic endophthalmitis due to your IOL, but it could be some ongoing inflammatory non-infective pathology, or it may even in an older patient be a neoplastic lesion. So when you have an uneventful initial period, and then you get this recurrence, you give topical and systemic steroids, and you get some kind of a partial response. And during this follow-up, you find some plaque in the posterior capsule, or if you find the hypopyon is coming now, or granulomatous capes, these are all signs that you may be dealing with propionobacterium acne. If you get recurrences after your intravitreal antibiotics, again, think you may be dealing with propionobacterium or a fungal organism. So you could try first doing a vitrectomy, but if you're getting a recurrence, you may do an IOL removal along with a vitrectomy, along with capsulectomy and wash of the capsular bag. And if that's one side, the other alternative is you can do a complete vitrectomy with silicone oil and endotamponade, and that could work too. So this is just to show you a patient who had chronic endophthalmitis with P. acnes and responded very well with IOL explantation along with a vitrectomy. Now, another kind of diagnosis may be of fungal, where the presentation could be weeks to months later. The important thing is symptoms are less, signs are more. Hypopyon is there, exudation is there. Sometimes there are fluffy snowballs, opacities in the vitreous. These are all signs of a fungal endophthalmitis. Now, when you do a vitrectomy in this case, don't forget, sometimes you could be confusing a lymphoma or an inflammatory pathology. So do a cytopathology examination of the vitreous along with the vitrectomy, along with the bacterial and fungal culture sensitivity and PCR for these patients. And look at the fundus picture. That will give you a good clue of what you're dealing with. For example, this kind of picture, when you did the vitrectomy and you find this kind of exudates causing an abscess, this is a fungal endophthalmitis. And this patient was treated by a vitrectomy with silicone oil and then managed with oral voriconazole in the presence of silicone oil. And you can see it responded very well. This is because silicone oil allows you to get very high levels of antibiotics in the just behind the silicone oil in the what we call the retro silicone oil space. The last thing is endogenous endophthalmitis, where you can have two important kind of clinical scenarios. One is you have a clinically moribund patient. Yeah, ICU mein hoga, or he'll be sick in the ward with septicemia, immunocompromised state. These patients may develop endogenous endophthalmitis. The second group of patients is a tricky one, because you may confuse him for pars planitis, you may confuse him for, you may not even think of endogenous endophthalmitis. These are ambulatory patients who have a history of IV dextrose, some kind of IV drugs, or some focal lesion, say some abscess in the foot or somewhere. If that is so, keep endogenous endophthalmitis in mind. The location can be either anterior or posterior. And both situations, it may be either focal, so you have small lesion, or you could have a diffuse lesion. The mainstay of, now the important thing is, unlike exogenous endophthalmitis, the mainstay of management in endogenous endophthalmitis is systemic antibiotics in meningitis doses. Even if you don't know what dose, ask the physician, what is the dose for meningitis for this antibiotic? That's what you need to give. Intravitreal antibiotics are reserved for very severe vitreous exudation. You can't see the fundus, you may want to add an intravitreal antibiotic. And in patients who don't respond with that, you may want to do a vitrectomy, preferably with silicone oil, because you can get very high levels of antibiotics after this. Just to show you one case of endogenous endophthalmitis here. This was a lady who had a history of fever for which she was given dextrose drip for many days and then developed this kind of lesion. She was treated initially with intravitreal antibiotics and systemic antibiotics, didn't get a full response, and then finally we did a vitreoretinal surgery with silicone oil, and then this started responding. You can see this went off virtually within a few days, and then after that, this was the final picture when it's stable, silicone oil been removed, and this is a membrane under the retina. This is another patient who actually got a blunt injury with a shuttlecock in one eye, had very high IOP, was being given mannitol on a daily basis, and developed loss of vision in the other eye. And this is what he had in the other eye. Somebody diagnosed it as a CNVM, but this is actually a retinitis, which is endogenous in origin. And you can see this is what this looked like. And this was managed only with systemic antibiotics. Within a week, the patient was here, and within 2 weeks, the patient had resolved. For endogenous endophthalmitis, it's very important, especially for the ambulatory patients, to have a very high index of suspicion, elicit a history of past infection or of IV use, be very aggressive in your management with high-dose systemic antibiotics and adjunctive topical therapy. And keep in mind, it could be fungal or bacterial. Silicone oil in endophthalmitis, we reserve for those patients where the endophthalmitis is severe, the exudates are up to the retinal surface on ultrasound, and when you do a vitrectomy, you find there is no PVD. These patients and patients with fungal endophthalmitis or chronic recurrent endophthalmitis or severe endogenous endophthalmitis all do well with a radical vitrectomy. We do a complete vitrectomy, create a posterior vitreous detachment if it's required, trim the vitreous skirt close to its insertion at the ora, remove all the exudates and inject silicone oil, which allows us to see during the post-op period, and the patient can also see. If you need any treatment, you can treat it, and there's rapid visual rehabilitation. I'm not showing the video because it'll take time, so we'll just go ahead. But I just show you that there was a huge difference in the response between conventional vitrectomy and radical vitrectomy in post-traumatic endophthalmitis in a study which we did. This is another patient where following an intravitreal injection, the patient got an endophthalmitis and managed with radical vitrectomy, responded very well. This is to show you patient who had endophthalmitis, managed by a conventional vitrectomy, got a recurrence. The IOL was removed along with this membrane, again got a recurrence, and then we finally decided to do a vitrectomy with silicone oil. And following this, the patient got 6/9 vision. The patient was aphakic, so when we removed the silicone oil, we did a sclerofixated IOL, and the patient is now, even more than 1 year later on, the patient has 6/9 vision. So, ladies and gentlemen, in patients with severe endophthalmitis, vitrectomy with silicone oil endotamponade, if done properly, has a very good prognosis, improves your visual outcomes, and can salvage both the vision and the eye. Lastly, you have bleb-related endophthalmitis, which is an acute endophthalmitis but late onset. The principles of management remain the same as for acute endophthalmitis. The take-home message is, ladies and gentlemen, in acute postoperative endophthalmitis, intravitreal antibiotics followed by intensive topical and systemic antibiotics and steroids as soon as you've got some response. Refer for vitrectomy all patients who show inadequate response to intravitreal injection in the next 24 hours. The usual core vitrectomy works for moderate severity of endophthalmitis, patients who have a PVD when you do the surgery. Radical vitrectomy with silicone oil works very well for severe endophthalmitis. But the important thing is that early intervention is the key to management. In post-traumatic endophthalmitis, bleb-related endophthalmitis, the same principles will work. And in endogenous endophthalmitis, please, if you have an ambulatory patient, do not think it cannot be endogenous endophthalmitis. Elicit a history of IV use or some local focus of infection prior to this. The mainstay of management here is high-dose, broad-spectrum antibiotics. If you need, you can add intravitreal antibiotics. If you get an inadequate response, quickly go ahead to a radical vitrectomy for your severe endophthalmitis. Will permit you to salvage not only the eye, but also give you an excellent prognosis for vision. As again, early intervention is the key to successful management here too. I conclude, ladies and gentlemen, with this. If you diagnose early, if you treat early, you will save most of your patients. Thank you very much. Endophthalmitis is a treatable disease, not to be considered as a horror, though it creates horror in our minds, it creates fear in our minds. But if we treat properly, if we treat aggressively, we should be able to save many, many of our patients. Thank you very much.
Thank you, Dinesh, for what should I call a all-inclusive talk on endophthalmitis. A lot of messages have been conveyed on this, and Dinesh becomes very, very emotional once he's delivering a talk on endophthalmitis, because between me and him, we have seen so many eyes which could have been saved with this regimen what he has proposed, which get lost because of delay or inappropriate management of endophthalmitis. Malika, would like to add anything?
Yeah.
Add or subtract, whatever.
Yeah, very good lecture. When you're doing the intravitreal injections, one point which we have to remember is that you have to remove first as much fluid as you are planning to inject antibiotic, because otherwise the eye can become very tense. So if the vitreous is not removable because it's very formed, then at least an AC tap should be done to at least create a volume as well as to get a sample specimen for microbiology.
Very important.
Yeah. So first remove, then inject.
Yeah, the alternative is you can give the first injection. Now the pressure goes up, do a little paracentesis and give the second.
Yeah, do paracentesis at least. Yeah. Second is that sensitivity.
Malika, before you go on, from medical legal point of view, I think it is important to send culture. Whether the aqueous yield we know is less, but it's from medical legal point of view, let us emphasize that aqueous agar nikala bhi hai thoda sa, like Dinesh is saying, put it in blood agar or sabroids or whatever you're suspecting, put in those things and document this. This is important. Okay. Yes, Malika.
Second is, yes, not all chronic inflammations are infective. There are patients who will have some cells but nothing else, no exudates, no hypopion, and they require prolonged steroids and settle down. Fungal endophthalmitis particularly requires what Dr. Talwar was saying, a complete vitrectomy, PVD induction, cleaning out the macula, because the fungus doesn't respond to our antifungal agents as the bacteria respond to antibiotics. So you will keep getting recurrences if the vitrectomy is not complete. The so-called CEVE, complete and early vitrectomy for endophthalmitis, is very important for fungal cases, very important. You have to induce a PVD. Not only recurrences, you end up with endophthalmitis maculopathy, where you have membranes on the macula, ischemia, scarring. So even if the infection is cleared, your macula is short if your vitrectomy has not been complete early enough, especially for fungal endophthalmitis. And
the message here is antifungal drugs are not too many, except voriconazole and amphotericin B. I don't think of any other drugs actually, although the rest of the azoles are all static, fungistatic. You see, only these two drugs most of us use. And amphotericin B, and this requires repeated injections if you have to depend on intravitreal. So this point is very relevant that if you have a severe fungus, which I recently operated from Srinagar, so you have to do a near total vitrectomy and spend a lot of time. Not even a trace should be left behind. And again, use silicone oil is very, very important in fungal endophthalmitis.
Clean the macula because aspergillus goes and settles on the macula, leading to large scars. So to clean the macula itself, you have to do a PVD to reach the premacular space. And then the last point is that in fungal infections, if they're not responding to amphotericin B, then the resistance to ampho is very high. So you should consider adding voriconazole to the intravitreal injections. Also, amphotericin B can cause hypersensitivity response. I've had patients coming back with hypopion following every ampho injection. So if you see hypopion following injection, it may not be reinfection. It may be a hypersensitivity to amphotericin.
See, this is one reason why I believe that a radical vitrectomy with silicone oil works better here. Because once you've done a radical vitrectomy, the voriconazole given orally works effectively.
Very well.
It does not work effectively in a routine. If you do even if you do a total vitrectomy, but if you've not replaced it and you've just left it on fluid, now the entire vitreous cavity again gets the whatever remnants of the fungus are there. And the penetration into all parts of that cavity is not good enough from oral treatment. So you'll keep on giving intravitreals again and again. So that is where doing the complete vitrectomy and adding silicone oil and then giving oral treatment is important. The other important thing is if you're giving oral voriconazole, you need to keep a watch on the LFT. Because if the LFT starts getting deranged, you have to stop it. So you have to be prepared that you don't want to give 4 weeks of voriconazole in a non-oil filled eye and then find that you can't give it once you've given the radical vitrectomy with silicone oil. But now your voriconazole is not possible because the LFT is deranged because you've been giving it for 3 weeks just like that. So that is what is very important.
Okay, I think any other point by Vishali or Partho before we ask? Yes,
I will
Vishali.
just add one quick point. Sometimes you are confused between very severe uveitis and endogenous endophthalmitis. If ever you are seeing a yellow glow in a patient of uveitis, it's not uveitis. Because howsoever the severe uveitis it might be, it doesn't produce loss of fundal glow. So the moment you have that, go in for vitrectomy or whatever Dr. Talwar said.
Very nice, very nice. Yes, Partha.
Yeah, so sir, excellent presentation, and as you very rightly said, the slides were excellent. I think the last slide is the best, and a very memorable slide. So, sir, one or two small points. One is the endophthalmitis after the trabeculectomy procedure or a drainage or a valve procedure is definitely much higher and goes up to nearly 5% in a 5-year follow-up. So patients who have undergone TRAB or valve or devices, their follow-up should be a lot more routine, and the possibility of the infection coming on even in a late stage has to be told to these patients. A small red eye, because these the mitomycin C or 5-FU might have been used, and the response of a redness or that amount of severity of redness might not be there, and might just be a very faint blebitis, yet endophthalmitis has set in.
Dinesh,
So
what do you do? What do you do to the bleb? Suppose you are doing a vitrectomy, and like Partho was asking about blebitis, and bleb is full of. Do you go ahead and do vitrectomy? You unroof the bleb, sacrifice the bleb. What do you do?
I will avoid the area of the bleb. I will avoid the area of the bleb. With 23 and 25, there is no problem doing that. With both 23 gauge vitrectomy and 25 gauge vitrectomy, you can avoid that. And the bleb per se, unless it's an abscess, it can be managed by topical antibiotics.
Yes, Malika?
Yeah, same thing. Very intensive topical antibiotics during the vitrectomy, fortified. And I have seen blebs which are completely abscessed. They recover very nicely. So they don't need anything specific.
The reason I asked this was because in one of the seminars I heard that you see bleb has to be unroofed. So I had to contest that. I said you put the betadine swab there multiple times, but if you do a near total vitrectomy with silicone oil and intensive, you see like we do in corneal ulcer patients, fortified antibiotic drops round the clock every 1 hour alternatively. This does take care of all the severe situation. I think let's move on because we have two very, very important talks remaining. And one is by Dr. Vikas. Vikas, can you share your screen? Because Vikas is going to dwell upon a topic which a lot of us do not understand much, is orbital cellulitis. And he will have a lot of take-home messages. And before Vikas, you start, there is an important announcement which I wanted to make. Tomorrow, that is Saturday, 26th, there is a very important course in Uveitis by Uveitis Society of India. People who are keen, who are listening, at 5 o'clock by Uveitis Society, and they will be emphasizing on FA and ICG in Uveitis. Yes, Vikas.
Good evening, everybody, and thank you, sir, for having me as part of this very unique and interesting session. So from retina and the inner part of eye, we now move out to the external part of the system. And I'll be talking about orbital cellulitis. Now, orbital cellulitis is actually the term which is used to describe orbital inflammation, which is caused by pathogenic organisms. Now, these pathogenic organisms can be bacteria, fungi.
Plus, can you maximize your slide? Can you increase this thing?
Okay, yeah. Is it okay? Is it okay now? Yeah. So these inflammations can be caused by either bacteria or fungi, or sometimes rarely tuberculosis or parasitic infestations, which are not uncommon in our setup. Now, these are potentially vision and life-threatening conditions, one of the few real medical emergencies in ophthalmology where life is at stake. The incidence has been reported to be more frequent in children than in adults in various studies which have been conducted across the globe. And so the incidence, if you look at it as per the data, it is quite infrequent, but in an emergency clinic, in ophthalmology emergency clinics where we were, these form a substantial part of the emergencies that we see, and some things which require a prompt diagnosis and management. Now, the source of infection in most of these cases can be attributed to contiguous inflammation, which comes from the surrounding structures, that is from the sinuses, face, or the oropharynx. Then just a moment, my slides are stuck. Yeah. So then you can have a history of trauma, which may have led to direct infiltration of the orbit with some bacteria or some microbes. Thirdly, there can be some foreign body which may be lodged in the orbit, particularly the organic foreign bodies, which have a high chance of having a polymicrobial type of growth over their surface, which can lead to a severe kind of an orbital cellulitis. And lastly, it can be a hematogenous spread, which is less common. Now, let's see few clinical situations and try to understand how orbital cellulitis can have varying presentation and different ways of in which it can affect. Now, this lady presented with periocular swelling of the right eye. There was swelling, there was pain, there was lid edema. But the important thing here, if you examine such patients, is ask them to rotate their eyeballs in all the gazes. And here the extraocular movements were full. There was no proptosis. And if you image these patients, as you can see a CT scan of this particular patient, you see that the inflammatory material is deposited in the anterior part of the orbit, or rather more accurately if we described into the preseptal plane. Now the orbital septum somehow acts as a mechanical barrier to the posterior extension of infections to some extent. And so in such a situation where you have this kind of a clinical picture with the imaging showing that the infection is limited to the anterior part of the orbit beyond the septum, preseptal, their oral antibiotics are usually enough. Another patient who has a more severe presentation with a lot of edema, a lot of erythema on the eyelid, mechanical ptosis happening here, and things look a little more worse than the first patient that we just saw. In this patient, one would suspect possibly there is some sort of orbital involvement as well. But when this patient was imaged on the CT scan, you see that luckily he does not have any posterior extension of the infection, and it is mainly a loculated, well-defined abscess formation, which is still confined to the preseptal part of the orbit. So this is again a manifestation of preseptal cellulitis in cellulitis, where you have a more diffuse involvement of the preseptal tissues. In preseptal abscesses, you have a liquefaction or the pus formation, which remains confined to the preseptal part. You can treat it with oral antibiotics, but this kind of a picture would require a surgical drainage for sure. Now compare the previous two patients with this patient. In this particular patient, a young girl who presented with a recent onset of swelling around the eyes, you can probably make out that the orbit is a little more tense in this situation. So we have lid edema on both the upper and lower lids. You can make out slight amount of chemosis here, and ask the patient to move the eyes in all these situations. And if the patient is having painful movements, there is limitation of movement. In the initial phases, it's just a painful movement of the eyes, which gradually progresses to limitation of movement. And you see, you get these patients imaging done, and what you see here on this MRI is, number one, there is opacification of sinuses. So there is ethmoid sinus which is full, there is a maxillary sinus which is full, and there is a lot of infiltration into the medial and the inferior part of orbit here. So this is a situation where the infection has gone into the orbit, posterior part of the orbit. So this is a case of orbital cellulitis or frank orbital cellulitis, as we are supposed to be discussing. Another patient who presented with proptosis, lid edema, and chemosis, unable to close the eyes. You see the air bubble in the anterior chamber. So sometimes these infections can even be iatrogenic. Now this patient was operated for a DSEC surgery, and the next morning when the pad was opened, the patient was in severe pain. Patient landed up in emergency, and this was the picture. So you see here what has happened is, with the peribulbar block, it has got some sort of contamination, and which has led to infection in the orbit. So looking at the CT scan, you can see that there is a lot of haze in the superior and the lateral part of the orbit. The scan is not of very good quality, but there is a lot of this fat infiltration, what we call as fat streaking in the posterior part of the orbit. There is a lot of proptosis. Fortunately, with IV antibiotics, most of these cases respond well. Another patient who presented with similar presentation, the orbit looks tense, there is proptosis, there is a swelling of the upper and the lower eyelids, there is pain, there is diminution of movements when you try to force open the eyelids. In addition, the patient also has a high-grade fever. So obviously it looks like orbital cellulitis clinically, but radiology plays a very important role in differentiating the various subtypes of orbital cellulitis. Now, in this situation, the MRI showed that the medial part of the orbit was involved. There was ethmoid sinusitis on both sides. There is infiltration of the medial part of the orbit. The soft tissues appear hyper intense here. But at the same time, what you see here is a hypo-intense collection, or rather a hypo-intense area. And this is like, surrounded by something which is convex, convex towards the orbit, adjacent to the medial wall of the orbit. So this is a subperiosteal abscess formation. It is important to get imaging done in all these patients so that you don't miss out on these critical signs. Most of these cases, as previously I mentioned, the infection comes from the sinuses. And because the medial wall of the orbit and the inferior wall of the orbit are the thinnest of the walls, and so it's easier for the infections to traverse or the microorganisms to traverse through these walls, through foramina, through the neurovascular bundles, along the neurovascular bundles, and so it can, and plus the orbit is a closed space, so sometimes there is a collection of pus underneath the periosteum, which is like this periosteal abscess, subperiosteal abscess. I'll be talking about the management subsequently. Another presentation where this young chap presented with obvious limitation of the movement in upgaze. There was a lot of chemosis, a lot of periocular edema, and intense pain, fever. Now, when you image this, this kind of a patient, which is which you can see here, the CT scan done here, it shows a lot of haziness, lot of kind of a mass kind of a thing in the superior orbit. It's not exactly a tumor or something. If you notice carefully, there is this hypodense area surrounded by a hyperdense adjacent tissues. So this hypodense area, this is how actually an orbital abscess in the initial stage can look like sometimes. You go looking in for a perfectly hypodense, round, cystic kind of a lesion. It may not appear so in the initial phases. It may just look like this. And once the pus liquefies, then you get those perfectly hypodense pus type of lesions in the orbit. Now, having an abscess in the orbit is a really serious condition, and this kind of a picture should never be missed. One should always get an imaging done because of what may follow, particularly in a situation like this where you have this child who presented with the superior orbital fullness, erythema, pain on movements, and fever. On imaging shows again a similar kind of diffuse hyperdense kind of shadow in the superior part of orbit. But what you see here, notice carefully that the superior wall of orbit has been breached and actually the abscess has invaded the brain. So this is a very, very serious condition where you will also have to involve a neurologist and a neurosurgeon. You have to drain the abscesses which have been formed now. So it's really a tricky area because many times we see patients who've been treated with oral antibiotics and they are kept on oral antibiotics for long without any imaging done. And when they land up, they sometimes land up with a situation like this, which can even be fatal if the infection goes deep into the brain. Particularly the abscesses in the orbit, which are formed in the superior part of the orbit. If the medial and the inferior part is involved, of course, it's not that critical, of course, because of the veins and going into the cavernous sinus, it's still important, but this part is most dangerous. Now, again, this patient, as I was mentioning, was kept on oral antibiotics for about a week or so after he developed the symptoms, but the symptoms were rapidly progressing. The patient was still on oral augmentin and stuff like that. And when he landed up, he had all the classical signs: proptosis, chemosis, extraocular movement restriction, high fever, headache. In addition, he was not oriented properly to the surroundings. His consciousness appeared little deranged and he was drowsy. In such situations, it's a dire emergency. You should refer the patient immediately for imaging. And what you see here in this patient is a dilated superior ophthalmic vein. And look at the cavernous sinus. Compare it with the cavernous sinus on the contralateral side, and you see there is dilatation of cavernous sinus on this side, affected side. So what we have here is one of the most dangerous complications of orbital cellulitis, that is the cavernous sinus thrombosis. So all efforts should be made that a patient with an infection of the lids or orbit should not go into this stage, as it's really very difficult to manage the patients at once they reach this point. There is almost 20% risk of death and vision loss. So all these changes can happen in the eye when you have orbital cellulitis. Orbital cellulitis can damage the various tissues of the eyeball. Number one, cornea can get exposed and it can lead to exposure keratopathy. There can be secondary glaucoma. There can be septic uveitis and retinitis. There can be exudative RD. There can be optic neuropathy caused by direct pressure effect of the proptosis and the surrounding edematous tissues, or it can be an ischemia of the optic nerve which leads to optic neuropathy. And it can even lead to panophthalmitis with when you see a lot of if you see a patient of panophthalmitis and then you get a CT and you see there is fat sticking in the orbit sometimes. So it can be a concurrent thing. So treatment is mainly broad spectrum antibiotics. We try to cover both gram-positive and gram-negative bacteria. We start with a third-generation cephalosporin and an aminoglycoside combination intravenously in orbital cellulitis cases, and observe for 1 or 2 days. If the patient improves, it's fine. Otherwise, we also add metronidazole for anaerobes. Some ENT specialists add metronidazole kind of or tinidazole in the beginning itself if there is a lot of sinusitis. MRSA cases have been increasing of late, and if your patient is not responding to the routine antibiotics, then you must consider MRSA as a possibility. If you can get some material from an abscess for culture and it shows MRSA, or if the routine treatment is not being effective, you can switch to vancomycin. And once the initial upswing has been stalled by giving IV antibiotics, then IV steroids have a significant role, which we normally start after 48 hours to 72 hours of starting antibiotics. And what it does is it actually reduces the tissue damage, which can be caused just by inflammatory process itself. And it helps in quicker resolution of the edema. It helps in quicker resolution of all the signs and symptoms, and it also helps to protect the nerve from the inflammatory mediators. So once the acute infection you feel has been acute infection has been taken care of, the disease is on a downswing, then adding steroids is not a bad idea. Surgical management is required if there is an abscess formation, whether subperiosteal abscess or an orbital abscess or an intracranial abscess. And if there is sinuses which are full and leading on to orbital cellulitis, FES can be done and sinuses need to be cleared up. And the third situation where surgical management is required in a patient of orbital cellulitis is a foreign body removal if there is a lodged foreign body, particularly an organic one, which may sometimes be difficult to diagnose initially. Now, abscess drainage is not required in all the patients of a subperiosteal or orbital abscess, particularly in children. Children lesser than 10 years of age are assumed to have or have been shown to have rather simple bacterial infections which respond well to IV antibiotics. And in these cases, usually just the medical treatment works. But if you have a patient older than, let's say, 10 years or a patient who's not responding well to IV antibiotics, then you need to go for abscess drainage. Obviously, if there are severe signs present like compromised vision, pupillary changes, raised IOP, if there is proptosis of over 5 mm, and patients who have optic nerve compromise, from compression by the abscess, then obviously this is an indication for an early drainage of the abscess. So this is in nutshell about the treatment of orbital cellulitis, bacterial orbital cellulitis. The discussion would be incomplete if I don't talk about orbital cellulitis, which becomes a unique situation in diabetics and immunocompromised. Now, in these patients, you have to be very, very vigilant, as it may actually be a sign of an underlying mucormycosis or a sinonasal aspergillosis or a fungal infection. I'll be talking about mucormycosis here, which is more likely to be confused with an bacterial orbital cellulitis. So what happens is that mucormycosis comes from the sinuses most of the times, and the infection invades from either maxillary or the ethmoid sinus. It's a very fulminant infection which rapidly increases to involve all the tissues of the orbit diffusely. It attacks the vascular lumina, causes ischemic necrosis of the orbital tissues. You may see black ischar formation on the eyelids or the periocular tissues. And the patients are usually sick. Patients are usually in ICU. They land up in ICU fairly rapidly. They have underlying metabolic disorders. They have an uncontrolled diabetes. So all that needs to be taken care of. And once you examine, you have to see how severe the problem is. You have to do a CT scan or an MRI scan to assess the orbital invasion. And also, don't forget to look at the fundus in all cases of orbital cellulitis, particularly in this situation where you have a patient who's a diabetic. And if you find a central retinal artery occlusion, in these cases, it's invariably mucormycosis in a bad diabetic, if it's a bad diabetic case. The treatment starts with a biopsy, which proves the presence of fungi, and biopsy is usually done by the ENT specialist. They go into the sinuses, maxillary or ethmoid sinus, take out tissue which you evaluate. And once you have evidence in favor of mucormycosis, then an extensive surgical debridement or even orbital exenteration may be needed. Of course, the treatment is started with intravenous amphotericin B, but you can't wait for too long. If the response is not good in 24 to 48 hours or 72 hours at the most, then you have to take a decision as to, and the condition is still progressing, you have to take your call whether you want to go for surgery or continue with the medical therapy. And most often, if the problem is not responding well to amphotericin B, then you should not wait too long and you should go in. Also, local irrigation with ampho B has been recommended. Hyperbaric oxygen, etc., are other supportive factors which you need to consider. Obviously, diabetes, needless to say, diabetes has to be kept under control. Lastly, orbital cellulitis may not always be orbital cellulitis, and you have to keep in mind the differential diagnosis. Some of the more serious ones are retinoblastoma, which may sometimes have an extraocular extension, which may mimic an orbital cellulitis, or it may just be an advanced kind of an retinoblastoma or a group E retinoblastoma, which causes inflammation of the orbital tissues. And in those cases, you give steroids for some time and see for the inflammation if it responds, and then you plan your chemotherapy accordingly. Rhabdomyosarcoma cases are known to present rapidly, and sometimes they may mimic an orbital cellulitis. But if your orbital cellulitis kid is not responding well to IV antibiotics, then do consider an alternate diagnosis and consider biopsy without further delay. Sometimes necrotic melanomas of the choroid have also, we've also seen that they present with symptoms similar to orbital cellulitis. When you image and when you look at the fundus, you see that the pathology lies elsewhere. Acute leukemia, acute T-cell lymphomas have also been known to mimic orbital cellulitis, and very rarely metastasis. So to summarize here, it's a real medical emergency and site-threatening. It's important to know about the condition. It's important when to go for imaging and when to refer, because any delay on this part may actually lead to loss of sight for the patient, and particularly in patients like who are diabetics or immunocompromised, it may lead to loss of life also. And you often require a team of an ophthalmologist, a good physician, an ENT specialist, and in more severe cases, neurologist or a neurosurgeon. Thank you very much.
Thank you, Vikas. It was a real eye-opener talk, specifically for people like us. It may not be for Santosh Honavar, but for us who rarely see such situations, often misdiagnose these things. And I'm sure people who are listening, who are more than 2,200 people listen to your talk. And believe me, it was an eye-opener. Santosh, uh, quick comments and take over. You see, the points which I wanted to emerge from here was he has described everything very well.
Yes, sir.
What intravenous antibiotics do you want to start? I can ask Vikas also. I thought
Right. So, but basically, we have to differentiate preseptal cellulitis from orbital cellulitis. That is the crux. If we are very sure that it is preseptal cellulitis, as Vikas has pointed out, there are clinical and radiological criteria. Then oral antibiotics are all that is required, and the most commonly used oral antibiotics is a combination of basically amoxicillin and clavulanic acid, that is augmentin. That is the most commonly used oral antibiotic. But if we have orbital cellulitis and it is bacterial, obviously you have ruled out fungus. And one good way of confirming fungus, which has as high sensitivity as endonasal biopsy, is sending a deep nasal swab. Nasal eschars are very common in mucormycosis. And if that on smear shows fungus, then you're dealing with fungus. Once you ruled out fungus, and if it's orbital cellulitis, the popular combination that is used is a third generation cephalosporin, such as ceftriaxone intravenous, along with gentamicin or vancomycin. So that is what we use, and metronidazole is added if there is significant paranasal sinus involvement. If there is an orbital abscess and that is anterior and accessible easily, then the first choice would be to drain it, because then you will get material for culture sensitivity. You can know the organism and its sensitivity. If it's a deep-seated orbital abscess, if the patient is not responding within 48 hours, then you should drain it. If it's a paranasal sinus associated subperiosteal abscess, again you have to drain it. Unless it's a young child and it is a ethmoid sinus abscess. Frontal sinus abscess has to be drained. So that I think.
And Vishal, Vikas, what imaging you made a very bold statement repeatedly that imaging is very important. What imaging a comprehensive eye surgeon should order for?
Sir, actually, both CT and MRI are good, and any of these can be used, whichever is easily available without wasting much time. So,
And
look at.
can he start the comprehensive eye surgeon, or people like me also? Can I start what all this after imaging, or it has to be referred to a Vikas or Santosh?
See,
it's a medical emergency, sir. Antibiotic has to be started after a good CT scan, and the CT has to be done not just axial but coronal and sagittal cuts as well, so that sinuses can be evaluated. So when a CT scan is sent for, it is a good idea to get a plain CT scan but with axial, coronal and sagittal 2 millimeter cut, so that when the patient is referred to an oculoplasty surgeon, the scan is already available in full complement. Otherwise, half-hearted CT scan is not going to help us.
I think people should know CT scan. You see, I myself may not be, I may just write because I have accessibility to Vikas. So we normally refer. And a lot of us are ignorant, believe me. We never order this axial, coronal, sagittal 2 millimeter cuts. Now that you have made us wiser, believe me, before I refer to Vikas, I will at least make a note on the OPD sheet. That was the whole beauty of, both having Santosh as well as Vikas with us. And like you rightly said, it's an emergency. We can start the treatment. And drainage, you see, is necessarily has to be a team effort with the neuro and ENT and ophthalmologist, or? Most
often, sir, because by the time a patient comes to you with an abscess, usually the sinuses are involved. So mostly it's a ENT and an orbital surgeon, which is a combined effort. Sometimes the ENT surgeons themselves also do it endonasally, and if it's a medial wall abscess. If it's a superior abscess which is associated with a frontal sinusitis or a frontal sinus abscess, then obviously it's a combined effort from both sides, from the ENT as well as from our side. But if there is an intracranial abscess, a subdural abscess, empyema, or epidural abscess, then obviously you have to also involve a neurosurgeon. But those are really bad cases.
And when do you want us to refer? Because like Santosh said, it's an emergency. You order for a CT, CT will become available to the ocular surgeon. We order all those 2 millimeter cuts, axial, sagittal, coronal, start the treatment. what should be the, apart from extraocular muscle improvement, fever coming down, leukocytosis coming down, pain improvement, when should we refer?
Pupil is involved, sir. If there is even hint of relative afferent pupillary defect or color vision abnormality or vision has dropped, then that should be an immediate indication for referral. I would say any orbital cellulitis has to be managed in consultation, at least with an oculoplasty or an orbital surgeon. Preseptal cellulitis anybody can manage, but if there is a pupillary involvement, then definitely it's an indication for immediate referral.
When does the admission is required?
Well, admission is required if the patient has systemic symptoms. If the patient has multi-cavitary involvement like paranasal sinus plus orbit, orbit intracranial, then definitely admission is recommended. If the patient has systemic signs and symptoms, then admission is recommended. Otherwise, antibiotics we can manage on a purely orbital cellulitis with minimal sinus involvement, we can manage as a daycare.
So
Yes,
you want to give an oral antibiotic or intravenous antibiotic?
In preceptal oral antibiotic,
I think
orbital intravenous
you can give oral, but orbit intravenous. इतना तो मैंने भी सीख लिया. It was, believe me, Santosh, Vikas, thank you for joining us. Believe me, it was an illuminating talk. Partho, Chairman Scientific Committee, last comment, because
learned a lot, sir, from the talks, and I think for the comprehensive ophthalmologist, again, it is best to be in conjunction with the neurologist as well as with the ENT surgeon when managing such cases, and when to shift from the oral antibiotic to the intravenous is always a difficult scenario. What is the limit till I think it is preceptal? Of course, the imaging techniques will show up, but how long to sit on the antibiotic regime oral, then to shift off to the intravenous means I have no clue.
No, I think she made it very clear twice that if it is preceptal by imaging or your assessment, oral should suffice. And if it is involving beyond that an orbit, intravenous has to be the mainstay.
So
I don't think they shift from oral to intravenous.
Yeah, look for any proptosis, look for any chemosis, look for any pupillary signs. Ask the patient if there is any pain or movement of the eyes, or if there is a movement restriction. So all these signs you can see in the OPD. And if any of these signs is evolving in a patient who initially you thought had a preseptal cellulitis, then any of these signs evolving, you must switch the patient to an IV antibiotic and then maybe get the imaging done as early as possible.
Yeah. And last slide of Vikas was very important. Masquerades, those are often missed. A child with a necrotic tumor or an adult with a necrotic tumor can manifest exactly looking like orbital cellulitis, and that should never be missed.
Yeah, tumors and all, chloromas. I saw one patient in RP center chloroma. So at that time, in any case, wonderful to have you, Vikas.
Thank you, Santosh.
Sir. Thank you, sir.
And we shift on to Rashmin. Before you start, there are already 8-9 questions for you.
Okay.
So, already. So in any case, we'll hear Rashmin, a pioneer and one of the last words in neuroophthalmology, to tell us what everybody should know and should not miss in optic neuritis. Over to you, Rashmin.
Thank you so much, sir. And I thank Dr. Lalit Verma and the entire team for involving me in such a very, very interesting concept. So the theme of the webinar is what we should know and what we should not miss. So let me walk you through a patient and let's discuss as to what are the things that a comprehensive ophthalmologist should be aware of if he's dealing with this kind of patient. So this is a story of a 42-year-old female who comes to you with an acute loss of vision in the left eye, and her visual acuity is 60 in the affected eye. The other eye is normal. She demonstrates relative afferent pupillary defect in the left eye. The right eye fundus and the fields are normal. And this is how her left eye disc looks like. And as you see, she has a florid disc edema with hemorrhages on the surface of the disc. So the first question that we'll ask as an ophthalmologist is what kind of optic neuropathy she is having. In a 42-year-old female with an acute loss of vision, two commonest optic neuropathy would be optic neuritis and non-arthritic anti-ischemic optic neuropathy. So the first step would be to say, how do we differentiate between these two? How do we confirm that patient is really having optic neuritis and not an ischemic optic? And what would help you would be the history, the examination of pupils and color vision, the appearance of disc, and the fellow traveler. In an optic neuritis, generally there'll be an acute loss of vision. Vision stays there or continues to go down for around 2 weeks. And after the onset of symptoms, after 2 weeks of the onset of the symptoms, the vision will start improving. And by 6 to 8 weeks, in a typical optic neuritis, vision will come back to normal. In contrast, in anterior ischemic optic neuropathy, vision will go down, and in 75% patients, the vision will stay there. In around 1/4 of the patients, there can be little increase or decrease of the vision in non-arthritic anti-ischemic optic neuropathy, and that depends upon the patient's, the status of vasculopathic risk factors, and in some cases, even the patient's renal function test. So that gives you a clue whether you are really dealing with optic neuritis. The other indicator that you might be dealing with optic neuritis and not any other pathology would be color vision. In optic neuritis, the color vision loss would be much more or disproportionately more than the Snellen's visual acuity loss, while in ischemia, both these would be parallel. Disc appearance, in a typical optic neuritis, when I say typical optic neuritis, the optic neuritis which has been described in one of the largest trials which was done in optic neuritis, which is ONTT, and there up to 70 to 72% of the patients had retrobulbar neuritis, the disc appearance. While AIOL, you will always a disc edema, which can be a sectoral disc edema, and you'll find that the other eye will have a small disc with a small cup, or what is described as disc at risk. Fellow travelers, in ischemic optic neuropathy, you will always have a vasculopathic risk factor or hyperhomocystinemia, while in optic neuritis, you may either have pain on movement, or you may have even a neurological symptoms like paraparesis or difficulty in maturation if patient has associated neurological disorder. So this is how, if you see a patient with an acute loss of vision, the first thing is to differentiate between optic neuritis and AIOL in most instances. The second step, so this is what we should know, that two commonest optic neuropathy in an acute loss of vision are inflammation and ischemia. There are other causes, but they are rare. Now, what we should not miss if you see a patient, and if we have determined that now the patient has optic neuritis, which is the topic of focus for today's webinar, the second point we should not miss is that, is it a typical optic neuritis or atypical optic neuritis? Typical optic neuritis is what was described in ONTT, generally associated with multiple sclerosis, while atypical optic neuritis generally would be other immune-mediated disorders like sarcoidosis, or two disorders which are now gaining momentum, especially in India and Asia, are NMO, neuromyelitis optica, and MOG. Now, these two are the names of the antibodies which can present with optic neuritis. Now, why it is important to differentiate between atypical and atypical is because the diagnosis or the neuroimaging that you order for, what you look for in neuroimaging are different. The treatment is different and the prognosis is different. And in some instances, a treatment for one, if instituted for the other, if you institute a treatment for typical optic neuritis to prevent multiple sclerosis, you might end up harming the patient if the patient actually has an atypical optic neuritis. So that's the reason why we should not miss a presence of atypical optic neuritis. So when do we suspect that the patient has optic neuritis, but it might be an atypical optic neuritis? First is absence of pain. Now, ONTT, 90% of the patient complained of pain. A similar study done in India, the patient coming back with a history of pain was a little less. Now, that can be probably attributed even to our threshold of pain tolerance. Presence of disc edema, again, as I said, 70% of the patient in ONTT, which is the study which defined typical optic neuritis, did not have a disc edema, while In our patients, we may have a little more Discrima, but presence of Discrima should always alert you that maybe you are dealing with atypical form of optic neuritis. Bilateral presentation, simultaneous or within a day, a couple of days, should always alert you to atypical optic neuritis. It is almost never seen in typical optic neuritis. And if patient has a bilateral presentation, our complete gamut of investigation changes. Severe loss of vision, no PL or a PR inaccurate kind of vision on presentation, it can happen in even typical optic neuritis, but we should be alert for presence of atypical optic neuritis. Complete lack or partial response to steroids. Recurrence can occur even in typical optic neuritis or MS associated optic neuritis, but recurrence with loss of vision or lack of response to steroids should alert you towards atypical optic neuritis. So now the first step was, is it really optic neuritis? Second step was, when do we suspect atypical optic neuritis? What investigation we should order? And this is very important because all this is what we should do and then involve neurologists, because neurologists would not have an access to a good fundus examination or all these investigations. Visual fields is must for both the eyes. If the eye which has an attack has a profound visual impairment, you may not be able to perform formal fields, but when possible, visual field for both the eyes. The visual field that I'll order would be HVF 30-2. OCT again is gaining a momentum to as a part of investigative tool in any optic neuropathy. There are controversies surrounding OCT, role of OCT, but it has some role in the investigative modality for optic neuritis. In multiple sclerosis, you might find that there is a RNFL thinning even in an eye which has not had an attack of optic neuritis. OCT is also useful to partly differentiate between optic neuritis because of multiple sclerosis and optic neuritis which occurs in neuromyelitis optica. Neuroimaging, please remember, CT scan has no role in the management of optic neuritis. It does not really tell you much except that it rules out the presence of compressive lesion. It does not guide you towards the diagnosis or management of optic neuritis. The investigation of choice is always MRI. And in MRI, the investigation that we have to request for is MRI brain and orbit with contrast. It might be a good idea to alert a radiologist that you are suspecting optic neuritis. He will then institute a suitable sequence like fat suppression. So neuroimaging, MRI brain and orbit with contrast always. In the olden days, we used to say that MRI is necessary only for prognostication in patients with optic neuritis. It does not really help you. If you do MRI and if you find a brain lesion, you know that that patient is at a higher risk of developing a neurological deficit of multiple sclerosis. And that was the role of MRI, let's say 5 or 10 years ago. But now I would recommend that MRI should be requested for in all the patients with optic neuritis. And I'll come to the reason in the next slide. Role of blood tests, if the patient had a loss of vision and it is improving, then the blood test may not give you any extra information. Otherwise, the blood test would be to rule out concurrent infection, or in the cases where you suspect infectious optic neuritis, the other blood test would be to know the presence of aquaporin 4 antibody or NMO antibody. Electrophysiology had a major role to play in pre-MRI era in the management of optic neuritis. Now the role of electrophysiology or VEP would be only when you are not very sure whether patient really has an optic nerve problem or whether patient is malingering. And in a rare event where you are not really able to differentiate between ischemia and optic neuritis, VEP may be an adjuvant, but it does not have a major role to play in the management or investigation of optic neuritis. So we should know about these investigations. Now, what you're looking for in HVF, the commonest visual field defect in optic neuritis is generalized reduction of sensitivity or central or centrocecal scotomas. Please remember, even optic neuritis can demonstrate altitudinal visual field defect, though it is more commonly described with AION, but even in ONTT, altitudinal visual field defect was fairly common. So presence of altitudinal visual field defect does not rule out optic neuritis. As you mentioned, OCT, RNFL thickness of 41 micron and a diffuse RNFL loss on OCT is highly suggestive of neuromyelitis optica, while in a typical optic neuritis, at least in the initial phase, there will be an RNFL loss mainly in the temporal area. Presence of RNFL loss after an acute phase is over also predicts the future disability. So OCT is gaining momentum in the management of optic neuritis. As I mentioned, MRI, and what we are looking for now is what are the features that you are looking for. If patient comes back to you with MRI report, what you should look for is whether chiasm and optic tract is involved. If apart from optic nerve, if there are lesions in chiasm and optic tract, you're probably looking at neuromyelitis optica. If you have an optic nerve lesion which is restricted to one segment, you're probably looking at optic neuritis of multiple sclerosis. But if whole of optic nerve is involved in the orbit, then you are looking at neuromyelitis optica. And that's the reason I said that MRI is important. Now, looking at MRI, you will be able to predict whether this patient is likely to be typical optic neuritis or optic neuritis associated with multiple sclerosis or optic neuritis associated with neuromyelitis optica or MOG. Now, these two are very important to know because if it is going towards NOB, NMO is an aggressive disease. It causes recurrence, it causes very fast neuronal loss, and it also causes within 1 year more than or close to half of the patient may develop paraplegia. And they are the people who come to us on day 0. So when the patient develops an optic neuritis, we still don't know whether he's going to go towards NMO. And these are the features which will tell you that, oh, we are suspecting NMO. And that's where you act fast and institute treatment, which we'll look for. So if you see an MRI report, look for how much of the optic nerve is involved, whether chiasm and optic tract is involved, even in the brain. The areas which are involved in NMO are completely different from multiple sclerosis. Typically, if you find a white lesion in dorsal midbrain, especially area postrema, is where you know that you are most likely dealing with NMO. And these are the patients who also will have hiccups and nausea. This is just to demonstrate this is what you're looking for. This is an MRI of a patient with NMO who had a ecopyrin 4 antibody in his blood, and you see that whole of the optic nerve here is lit up, and so is chiasm. This image I have taken from American Journal of Neuroradiology, again to demonstrate the areas which are involved in NMO, which are not involved in MS. Like here, you see that there is medullary involvement, thalamus involvement. So in other words, NMO, you can also ask for other history when you look at these patients, whether the patient had weakness of legs, arms, loss of sensation, vomiting, hiccups, or bladder or bowel dysfunction. So what should we know? If you are suspecting NMO, what at this point in time, in most instances, a neurologist would have come in the picture, or neuro-ophthalmologist would have come in the picture. And what they will do is ask for a blood test, which is ecopyrin 4 antibody or NMO IgG test. The NMO is also associated with other immune-mediated disorder, so a blood test for like C-ANCA, P-ANCA, and in most instances, you will also ask for lumbar puncture. In lumbar puncture, a neurologist is looking for presence of WBC, which is seen in higher concentration of WBC is seen in a lot of these patients with NMO. They'll may also look for oligoclonal bands and presence of other inflammatory markers or presence of infection. What should we know about the treatment as a general ophthalmologist? As I said, these patients come to us first, and these disorders, atypical optic neuritis, especially NMO associated disorders, or what is also called NMO spectrum disorders, are extremely aggressive, and we should know that all these patients should get IV steroids as soon as possible. Now, this is contrary to what we learned, let's say, a decade ago. A decade ago, we were told that optic neuritis, in most instances, is a self-limiting disease. It does not matter whether you give steroids or you don't give steroids. At the end of 6 to 8 weeks, patient will have a vision which he would anyway would have got even without steroids. That's not the case with NMO and MOG. Now, it is believed that within 48 hours, you should have instituted steroids, because that will help us to blunt the further recurrence, and surely it helps us to prevent or delay the onset of paraplegia. lot of neuro-ophthalmologists now are going for plasma exchange very early in the management of neuromyelitis optica. The reason being, it's an aggressive disorder. So if patient, and I'll summarize and tell you that what are the features which suggest that this patient would require a very aggressive treatment apart from steroids. A chronic maintenance therapy would be required for a very long time in these atypical optic neuritis associated with neuromyelitis optica. Generally, neurologists, and this is all in the realm of neurologists, but just for knowledge sake, that azathioprine, mycophenolate, or rituximab are the immunosuppressive agent which are typically given for longer period of time. The good news is that there are newer drugs like tocilizumab or eculizumab, which has been proven effective to prevent paraparesis in patients who have positive ecophorin 4 antibody in their blood. A similar disorder like NMO, which again we are seeing more and more in India, is MOG, which is again antibody to MOG, which is a similar spectrum. Like they also have optic neuritis and transverse myelitis, but they have more association with encephalitis. It is much more bilateral. It is more likely to be, so MOG antibody, if you find a MOG antibody in the blood, you know that patient is going to do well as far as the vision is concerned, because the recurrence rate is much lower in MOG versus NMO. It has a better recovery. And how do we clinically say that this patient will require a blood testing for MOG? Is when you look at MRI, you'll find that in MOG, patient associated with MOG neuritis will have what is called as perineuritis. There's inflammation around the axons of the optic nerve, which might actually spill over in the orbit. And interestingly, a lot of patients who are COVID, not a lot of, but patients who are COVID positive have demonstrated optic neuritis with MOG positivity. So there is something happening there. All these patients will require early treatment and chronic immunosuppression. Again, NMO and MOG, other important things to know is that in a typical optic neuritis who might be going towards MS, typically neurologists will give them interferon. While if interferon is instituted in NMO or MOG, actually it will increase the recurrence and patient will do very badly. So that's again a reason why role of ophthalmologist and neuro-ophthalmologist comes in, that you might have to inform the neurologist that we are suspecting these two, and accordingly he will treat. He'll make sure that the immunomodulators like interferon are not given if you're suspecting NMO or MOG. So to summarize, atypical optic neuritis can be immune-mediated, while a typical optic neuritis generally would have a benign course. Immune-mediated optic neuritis can have an antibody in the blood with a systemic condition or without a systemic condition. So with antibody and no systemic condition is what we are more likely to see, that is NMO and MOG related antibodies. If there are no antibodies, then you have a systemic condition like sarcoidosis, which will also have most of the time concurrent vitreous cells or even anti-uveitis, or a no systemic condition. Then you are looking at a condition called Creon. To summarize, so that was in brief what we know about optic neuritis. What should be the red flag for us? A profound loss of vision with disc edema, or if you see bilateral presentation, both eyes getting affected simultaneously or within a couple of days, MRI showing involvement of entire optic nerve or involvement of chiasm or optic tract, all these patients should be referred to neurologist early, and they should be, we should mention that all these are present so that they may look for NMO antibody in the blood, and then they institute early treatment, and they also would give immunosuppression. All these patients we should follow up and do HVF and OCT at subsequent visits. Thank you very much.
Thank you, Rashmin. The fourth wonderful talk we had today was again for us truly illuminating. Sumit, how many of these patients nowadays, because a couple of days back only I heard that you see reported in American Academy somewhere that MOG in this COVID era has increased quite a bit. Is that true, Sumit or Rashmi?
Yeah, thank you, sir. So I think that is something we have to really watch for. We are still evolving in terms of our understanding. Like MOG, just to emphasize, it was just discovered in 2017. Like it's just 2 or 3 years. So as we are actually discovering more and more serum biomarkers, our understanding is really growing, So whatever we labeled as idiopathic demyelinating optic neuritis, more and more of that chunk is actually, being categorized either as NMO or MOG, or maybe, any biomarker that we will discover, soon.
There are two reasons, Rashmin, I was asking this because my good friend Dinesh also said he is seeing a couple of patients of neuritis. Then I happened to read in American Academy somewhere that MOG has increased. So I thought I'll ask, from the horse's mouth. Yes, Rashmin.
Yeah, absolutely, sir. There have been reports of optic neuritis with MOG positivity, and those patients are also they happen to be COVID positive. Now, these are all, as Sumit mentioned, these are all antibodies which are circulating, and maybe in one way or the other, infection might be triggering that response. We are not very sure about it, though most of the other neuro-ophthalmic findings in COVID has been related to thromboembolic phenomena.
Yeah, I have seen a patient recently with bilateral vision loss that started along with the COVID infection, and his pupils were brisk, fundus is normal, there's a secocentral scotoma, color vision was lost, defective. And then we started him on IV steroids, and there was partial recovery of the color vision within 3 days. Subjectively, vision improved from 6/36. No, subjectively vision improved, but not objectively. It remained at 6/36. Color vision improved, so even objectively. So I don't know what that was.
That smells like MOG, because bilateral simultaneous presentation is highly quite common in these MOG related optic neuritis. And again, as Sumit mentioned, that there has been, and as Dr. Lalit mentioned, that there have been now reports that MOG related optic neuritis is seen in this COVID positive patients.
Maybe it is not seen in those who are given steroids as part of COVID infection treatment. Now, this patient had not been given steroids. He was treated at home with vitamins. So possibly if they are given steroids as part of COVID, maybe it doesn't happen. I do not know.
Oh, yeah, you see, Sumit, like I asked Vikas and Santosh, for a comprehensive eye surgeon, or even for people like us who don't see much, our job is to, maybe diagnose any patient who has sudden loss of vision and VER is gone. That is the only thing we do. Electrophysiology, visual fields, sudden loss, refer to Sumit Monga. So what else should we do for a patient who has, like he said very clearly, neuritis vis-a-vis the ischemic component? So shall we start the steroids? You want Sumit to start steroids and send it to you, or do some imaging and send?
Yeah, so I think here we have to understand, because it's very easy that, okay, a neurologist has to be involved, and, obviously we have to take his guidance and supervision, for IVMP and all. I'll just give you two small examples, which I just happened to see in last 1 month.
Yeah.
So a young female actually, came to us, she had 6/6 vision and 6 vision, but somebody noticed that, she had a pupillary involvement. And that pupillary involvement was basically an efferent pupillary defect. It was like a 5 millimeter pupil, which was basically because of the ADs. And would you believe it? That patient actually had IVMP course because she was referred from the ophthalmologist to the neurologist, saying that, this pupil involvement is very dangerous. And, so the primary diagnosis was never there. And another female actually was there with PL negative vision, another eye 6/6 vision, was diagnosed as retrobulbar neuritis. Everything was normal, like on examination of fundus and all. And she was given IVMP in a village in Haryana and referred, and her eye, in this imaging showed no space occupying lesion. And on close examination, actually, her pupils were absolutely brisk. Just to document the optic nerve conduction, we had beautiful, VEP waves with normal latency. And when we did the malingering test, it turned out to be malingering. So the primary diagnosis of optic neuritis, the clinical examination cannot be overemphasized. So the biomarkers, the imaging, everything is secondary. So I think the clinical examination is something, which the art should not be lost. And as regards to your specific query, sir, see, if we actually understand why we're doing imaging for, as Dr. Rashmin sir just mentioned, I think one of the primary thing is that we are actually, wanting to see what is the extent of, the involvement, whether it is just the optic nerve or the brain, which is in the demyelination is getting involved with, or is there a space occupying lesion? Because there have been, cases of compressive optic neuropathies which have presented just like optic neuritis. And, that has to be, like ruled out. So basically, when you say imaging, a contrast, brain and orbit, and specifically in T1 weighted images, you should be seeing enhancement of the optic nerve segment, and you should specifically order flare sequence, which basically means that you are suppressing the CSF around the perimentelar area in those sequences, and the demyelinating plaques can get enhanced. So unless you actually specifically say to the radiologist that we are suspecting optic neuritis and we are wanting to rule out any evidence of multiple sclerosis, he may miss it, because we had cases referred to us with no contrast, and sometimes just CT scan, and because nothing was visible, they were diagnosed as retrobulbar neuritis.
Yeah, Rashmin, you were wanting to make one point.
No, so as Sumit very beautifully said, that there are a lot of times you will find that the steroids are overused. And one third condition, he mentioned about Itis pupil and malingering. The third condition, which also we find that diagnosed as optic neuritis, is in a lot of instances would be uveitis. A posterior uveitis can have a spillover, a swelling of the optic nerve. So optic nerve is not the primary seat of inflammation, but it's a spillover inflammation. And then the diagnosis is made as optic neuritis. Patient goes to a neurologist. He obviously starts the MRI. He advises MRI and starts steroids. Patient responds beautifully to steroids, because that's the first time treatment for posterior uveitis as well. But then we are on the wrong track, because the investigation that he requires from the posterior uveitis part is not done. So what was emphasized by Dr. Vishali and everybody is also to make sure that the slit lamp and the fundus examination is done. Look carefully for vitreous cells and anterior segment inflammation in all patients where you suspect optic neuritis. Because that might.
Vishali and Dinesh both had emphasized this. You see, one other thing which we learned, and I am sure a lot of other people, is that people just write vision, CT, MRI, oblique. A lot of times I've seen CT oblique MRI without knowing. So very clearly, I think both Rashmin and Sumit have told, CT has hardly any role except to rule out maybe some compressive lesion or what. But otherwise, MRI is the investigation of choice in neuritis. Yes, Sumit.
Yeah, so just a word about IVMP. You were mentioning that whether an ophthalmologist should be, giving. So I think what we need to understand is that IVMP administration is a, very technical, specific job. So if you have come to a conclusion that, okay, we are dealing with an optic neuritis, it could be, demyelination of any kind, whether just a MS related or MOG related or NMO related. I think the safe thing, an ophthalmologist can do as an emergency is, yes, you can administer IVMP, but then it has to be done under really good medical supervision. I have seen, many people who actually had cardiac issues, and, you just did it. The sister was just doing in a ophthalmology setup, and then you had, systemic problems. I had a patient, who underwent into, who went into psychosis, with IVMP. So unless you have actually informed the patient and obtained basic information like serum electrolytes, or the sugar levels, other things, monitored well by a physician, IVMP should not be really, casually treated. It should be, really under treatment of a physician.
Any other comments by Abneendra or Partha Vishwas on?
I would like to make a comment.
Yeah, Vishali.
I think besides what Rashmin said, another point is the infiltrative optic neuropathies. So if your disc appears lumpy, bumpy, yellowish, it might be, malignancy hiding somewhere in the breast and all. So that is also something which is very often missed is the infiltrative variety and confused with posterior uveitis. But I guess one has to be very careful because you keep on giving steroids, the appearance changes, and then you get into false sense of this that it's responding. But that is something which has a very characteristic appearance.
You see, one very important point we learned
In fact,
also
ma'am,
apart from imaging. Yeah, Rashmin, first you make it.
Yeah, sure.
Rashmin.
Yeah, in fact, the patient that I showed actually turned out to be an infiltrative optic neuropathy with that florid disc edema.
That florid kind of a thing. Even lymphomas and all, you have to be very careful. So
you see, if a patient of neuritis, suppose somebody has started the steroids, IVMP or oral, and if he's not improving in a couple of days, please refer it to a neuro-ophthalmologist.
You might be missing out
on. Other thing which I've seen in my OPD also, patient on steroids for a long time and nothing is being done. So that's another lesson learned. Yes, Avnindra and Partho.
The one point I like to make about neuritis and ischemic neuritis. One clinical point, ischemic neuritis is a pale disc edema, while optic neuritis is an aggressive red disc edema, and that is how you differentiate between an ischemic optic neuritis and an inflammatory neuritis. Second thing, in these in recent COVID era, we have seen more incidents of retrobulbar neuritis, patient coming with decreased sensitivity, and we start them with oral steroids, and they tend to improve within a week or so. So I'll like to know opinion of Dr. Rashmin and Sumit. What is your experience with retrobulbar neuritis in COVID era?
Can I ask Dinesh to comment because he had a couple of patients. Dinesh, can you please enlighten?
I think I mentioned to Lalit also, and I've been talking to others also. I think we all, I noticed it because in the lockdown, I was still doing my OPD for all patients who came with emergency. And there are a lot of patients who came with sudden vision loss in both eyes. Many of them had bilateral, some had genilateral, and the fields showed altitudinal defects also. And, unfortunately, because at that time, COVID was a bad name. And, just writing COVID on someone's file meant that that guy may be ostracized from society only. So I wasn't writing COVID, and I just sort of let them get the treatment, and I would refer to the neurologist. And not all, but some of them did respond to the steroids. Then that's the other point, that how do you get to know which patient will respond and which not? Or is it only a therapeutic trial? This is one aspect.
Sumit,
so
what about what Dinesh was telling you?
Yeah, so I think, sir, I think in this case, if the primary pathology, we are labeling it as optic neuritis, still, I would not really start them on oral steroids, because if it is really, optic neuritis, even if it resolves, it might actually have a big recurrence. So oral steroids, I would not say the message should be that, we should be starting the patient on oral steroids.
That's
Maybe
not the first line.
Yeah.
You send to the neurologist and say, you take care of the rest.
No, I think still, while sending to the neurologist, the thought process should be that, okay, if we are labeling them that as optic neuritis, maybe we should order the biomarkers, like a MOG or NMO, because it's a bilateral involvement. And if we thoroughly investigate it, like getting the spine MRI, and along with that, then that will help the neurologist, really come to a good conclusion.
Are these biomarkers easily done or available, NMO and MOG?
Yeah, it's done, sir. And one more point here for the general ophthalmologist. Many labs actually are doing biomarkers, using non-cell-based assays. So when you say that, we have to get a anti-MOG antibody or anti-NMO antibody, it's preferably to write, cell-based assay. Because if you are actually getting it from Western blot or ELISA, like those would be falsely negative. And then the whole, scenario changes. So I think that is also one takeaway.
How do you know whom to send to? So you may write that, you don't know whether it came that way, whether it was done or not.
Yeah,
Generally,
that's very important because the thing is, we at Center Site have an option, okay, refer to Sumit Moga. But for
generally,
general ophthalmologist, how and where they should refer?
yeah, generally, I know financial interest involved, but all the big labs like SRL and like Lal Lab, they have started doing cell-based assays with immunofluorescence. So that's
But
what. Yes.
would you wait for the results of NMO and MRIs before you start steroids? Because it might take, quite long to get MGO and
Sometimes it will
MN.
take a week or 10 days to give you the
Weekend.
Yeah.
Yes,
So
yes.
you want to give IVMP, some of these patients as soon as you want to, because even if you are over treating, it's still worth it sometimes.
Absolutely. So IVMP is basically working in all of the entities anyway. So
Anyways, yeah.
it's basically the labeling is important for the chronic phase. The once you're through with the acute phase, because the treatment actually is changing for the three. If it's just a demyelinating, you would just want an IVMP with oral steroids for 2 weeks and then follow up for multiple sclerosis, along with the neurologist. If it is NMO, IVMP, or a plasma exchange, if you are able to document that, okay, this is an NMO, in the West, they have a very low threshold. I don't know, about Dr. Rashmin's experience, but plasma exchange is a very, effective treatment that they're working on. And then we have to realize that if we actually had mislabeled it as a MS related and started the patient on interferons, the neurologist sometimes does that. That is actually detrimental in NMO patients. So the labeling has to be correct. But that is, for a little more later phase of the management. First, IVMP can be given in either of the entities. So that actually, I think, if a general ophthalmologist is seeing as an emergency, they don't lose much. Obviously, this has to be under monitoring.
See, I have a question regarding this. Very often you get patients who are diabetics, right? And they get the same picture. Now what do? You don't want to, in fact, the physician is not interested in starting IVMP in them. So would you say no?
Dr. Rashmin, sir?
Yeah, so I think that's the reason why I said that MRI becomes extremely important. Now, previous era, we said that anybody above 40 with a disc edema, diabetic, more likely to be ischemia and not likely to be optic neuritis. But now we are saying this NMO can be seen even in the age of 40 or 50. MOG can be seen in 30, 35. They can have a concurrent diabetes. So most of these patients will end up doing MRI, especially when the vision loss is very poor. If the MRI shows a clear indication that this is going towards NMO, then obviously explain the risk to the physician and to the patient that if you don't take steroids, you're likely, in all probability, you'll lose this eye very quickly. And within a year, very high chance, 60% chance that you develop paralysis. So anyway, you control your sugar and get the steroids done because that is extremely important. So I think the steps for a general ophthalmologist would be acute loss of vision, pointing towards optic nerve because there is RAPD and color vision loss. Get the MRI done, and that is important, not a CT scan, MRI brain in orbit with contrast. MRI shows either, as Sumit mentioned, optic nerve is lighting up, chiasma is lighting up. You know that you are dealing with a optic nerve with a neurological disorder. Get the neurologist involved fast and say, this is how the optic nerve picture is. So he will then take over, make sure that acute optic nerve, IVMP is given, blood is given for NMO and MOG. If it comes back positive, then it, start the disease modifying agent accordingly. Sumit?
I think we have had, Sumit.
Just one last thing. I think, the diabetic thing that you mentioned, I think it's not unusual that, good physicians do accept these patients and start the patient on insulin. We know that the fluctuations would be there in sugar level, but the emergency, is such that we have no choice. So generally by insulin, they are able to manage it.
Yeah, Partho, any comments?
Yes, so excellent discussion, excellent presentation, both by Sumit as well as Rashmin. The one thing that is a very, very important take-home message, I'm sure all of us have got it, that is differentiating between the typical and the atypical, because if we are treating a typical, then the chance of a visual loss a permanent visual loss is definitely much less, even if a comprehensive ophthalmologist has erred on the wrong side, has not given IVMP, and I mean, the natural course of the disease might not have an irreversible visual loss, whereas an irreversible visual loss will definitely be there if it is an atypical neuritis. So that is very important. And the other thing is, after the IVMP, the course of the oral steroid, would that be 2 weeks or would it be 3 weeks? Or would that depend upon the recovery?
So it'll depend upon two things. Again, as I'm going back, if the MRI is normal or is showing any of these, then nowadays IVMP is being given for 5 days and the oral steroids are given for longer. Now that 2 weeks was limited to optic neuritis associated with multiple sclerosis. So if you don't have a neuroradiologist or neurologist is sure that there is no evidence, MRI picture of NMO, then you can have 2 weeks of oral steroids is fine. In fact, in the West, they've stopped giving oral steroids altogether. They say 5 days of IVMP is good enough. But if it is pointing towards atypical optic neuritis, then a longer course of steroids are required, and then immediate going towards azathioprine.
I think we all of us had great learning today. We learned from each other, and I'm sure if we had learned the entire audience, which still usually I got this figure 1800 plus still logged in, they all must have gained from wonderful presentation. Start with Vishali, Dinesh, then Vikas and Rashmin. I am extremely thankful to all the and the panelists. We had some audio and the panelists, they added a lot of value to, you know, bringing out the clarity from all these experts. And words are not enough to thank the team of M&M and you see Manoj Mahajan and Mukesh who cooperated so much, and Karishma as well as that Raju who is always there to help us. So some words by Manoj Mahajan.
Yeah, thank you, sir. Thanks a lot. So first of all, good evening to all. I would like to thank Dr. Lalit Verma for creating ITS series, an interesting program, and with a team of great experts, Dr. Vishali Gupta, Dr. Dinesh Talwar, Dr. Vikas Manan, and Dr. Rashmi Gandhi for their exciting talks and wonderful learning. And I would also like to thank the panelists, Dr. Malika Goyal, Dr. Santosh Unawar, and Dr. Sumit Monga. As Dr. Lalit has mentioned, you know, you have contributed to the discussion and make it more worthwhile. And finally, I would like to thank Dr. Lalit Verma, the chairperson, along with Dr. Partha Biswas and Dr. Arvinda Gupta for navigating the discussion with the take-home messages, which I'm sure would be benefiting to all. Thanks everybody in FIT for such a wonderful audience. And once again, thank you, Dr. Lalit Verma, for entrusting on Wilmette and giving us this opportunity to.
All of us enjoyed, you know, having discussion, and I am sure speakers also must have enjoyed presenting their viewpoint to the, you know, all those audience glued in. And I will try my best to bring out some kind of written document. I may need some material from you so that this some kind of algorithms, as Vishali somebody was asking, so we can have, you see, because if we are learning, I'm sure a lot of other people are learning. So like like Rashmin summarized, you know, a minute back, these points of neuritis, sudden loss, CAT scan, MRI, investigation, similarly what Dinesh said and what you see Santosh as well as Vikas said. So in case we can, you know, give it to say Manoj for, you know, helping us in dissemination, that will be a wonderful idea.
Nalit, it would be very nice if Rashmin could give an algorithm based on step 1, step 2, step 3.
That's what I was saying.
And then the
all the ITIS components, 8 we have covered. And all of them, I think I will try to accumulate all this and will require help from all of you. With these words, I think I once again thank the Sun Pharma team and the excellent presentation by 4 talks, 4 speakers, and excellent job done. Malika, thank you. Where had you disappeared?
Thank you, sir.
Malika is going to operation theatre now. Mukesh, any words? Because Mukesh is a silent man, silent worker.
No, sir, just thanks to you, sir, for initiating such a wonderful webinar on Itis. It's your guidance and the direction which help us to deliver the best of the academic program. And of course, the thanks to all the eminent faculty members and the panelists who makes the entire.
Meningitis, let's not keep repeating. Thanks to everybody. I think we are grateful for all the speakers and panelists.
Yeah, of course, sir.
Thank you very much, and have a safe life, and good night to all of you.
Thank you, sir.
Thank you, sir. Good night, everybody.
Thank you.
Thank you so much.
Bye. Thank you, Vikas, Malika.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
For joining and contributing so much, AG.
Thank you, sir.
Lashmin.
Thank you, sir.
Thank you so much.